Good morning. I'm Don Meuten here for the C.L. Davis short course on gross pathology. This morning's talk will be on horse pathology, and I'd like to thank in particular Dr. Bruce Williams and Dr. Sam Thompson for getting me here. It's always a pleasure to come to DC and participate in their short courses. With that introduction, let's have the first slide, please. The handout goes through various body systems, and we started off with the musculoskeletal system and dwarfism. And no, that's not a horse, nor is it a mistake, but it looks pretty similar in any of the species. We've got symmetrical and asymmetrical dwarfs. This is obviously an asymmetrical one, and then we end up selecting certain breeds based upon that. The doming is one of the characteristic features. Various other tendon, ligamentous problems come with those dwarfs. They're subtyped in other species too many small categories, and basically it's an achondroplastic lesion that results in a lucency on radiographs in the epiphysis or physeal region of multiple bones. Appositional growth tends to be adequate, but in fact excessive, but longitudinal growth is deficient because of a failure of an ossification center amongst one of the many defects to develop in the epiphysis. Epiphysis, physis, metaphysis, and there's just a small ossification center that's formed, so that the remaining epiphysis is just a cartilaginous cap and characteristically mushroom shaped. And then various degrees of ossification centers will form in other bones. They can result in crooked limbs along with lots of other defects. In the adult individual or the young growing animal, it's very often an abnormality in the physeal plate. In youngsters, there are syndromes called arthrogryposis that are related to CNS and or muscle lesions, but not directly in the skeletal problems. The crooked limbs are due to inability for those limbs to move in utero, and they end up in these various types of flex position. Usually it's a CNS lesion. It can be hereditary in certain breeds, and it can be associated with the exposure of different toxins, including lupines. One of the other lesions that usually accompanies it is palatoschisis. In foals, various types of crooked limbs and valgus and various deformities can occur. Many of these will straighten out simply with exercise. When they're this severe, usually surgical correction is required, and many of those with a periosteal reflection will turn out to be adequate. These folks that have various degrees of rotation, valgus and varus, deformities, are usually related to some problem in the physeal plate. In the bone on the bottom, the physeal plate is completely closed, and the one at the top, you can see that this end is still growing, and you can have cartilage with some hemorrhage around it, and on this end it's closed prematurely. There's a small piece of woven bone that forms over this area. This end of the bone is going to stop growing. This will continue to grow because it has a physeal plate, and therefore the limb bone will be crooked, and then the entire limb will also bend. So depending where the trauma is, the epiphysitis, the physitis is located, the physeal plate will close prematurely, and then the limb will bow in various degrees. Or you can have entirely crooked carpi, or areas over here that are bulging due to ruptured tendons. This is seen in foals with hypothyroidism, primarily the northwest U.S., Canada, and they'll have various abnormalities, including crooked limbs, prolonged gestation, and rupture of flexor tendons. That's too many limbs in case you haven't figured it out, and this isn't a paint, but it is a little Holstein, and you can have multiple extra limbs. If you really want to see anomalies, especially the skeletal system, go to a hatchery, and you'll see every type of problem in existence. And then you can have horses with extra limbs and or digits, is exemplified here, or you can have a truly three-legged lameness, in which case we've got amelia of one of the front limbs in this little foal. They're just congenital defects and they're no great shakes. Here's a paint horse with tiny little feet, and now you can find out if I've fibbed to you in any regard. But here's a little Holstein with a mule foot type of problem, in which they've got the dew claws of the cow and then a single foot that's developed. All sorts of anomalies in various species. Metabolic diseases, probably the most common in the horses, would be nutritional secondary hyperparathyroidism. You can have it with renal secondary hyperparathyroidism, and you can see the animal is in overall poor nutritional condition. The right limb is bent forward, which may in fact indicate a lameness. Typically they'll have shifting leg lamenesses. And then here's either an ugly head or the start of the big head of fibrous osteodystrophy in the maxillas. Big carpus, for some reason, lots of reasons for that to occur, and with the fibrous osteodystrophy of the maxilla, you can also have the same lesion develop in the distal ends of the appendicular skeletal system and make for these epiphyseal flarings. The microscopic lesion is one of fibrous osteodystrophy, proliferation, and then new bone will continue to be produced, but it is generally not mineralized, and overall the lesion is soft. And then there's all sorts of eponyms for the condition, all centering on the idea that the nutritional problem of calcium-phosphorus imbalances result in a fibrous osteodystrophy and actually enlargement of the bones. That's just one of the classical substances that's associated with it. Depending on the species, it'll be a different food product, but usually the key thing is excessive amounts of phosphorus or a calcium-phosphorus imbalance such that it'll stimulate parathyroid hormone secretion, which then leads to these lesions. The calcium may in fact never leave reference range, even though it could be deficient in the diet, or that calcium could be within reference range and it's just an increase in phosphorus. But the imbalance is such that it results in a relative decrease in calcium, even from the high concentration of phosphorus, and therefore stimulates the parathyroid gland to secrete parathyroid hormone. There's multiple ways to produce this problem through inadequate nutrition. Key to the diagnosis of that is to measure dietary concentrations of calcium and phosphorus, and/or in the patient to measure parathyroid hormone, or done more easily, the fractional excretion of phosphorus. Let's not go through this awful formula, but it's very easy to actually do, and you can see that the reference range for phosphorus excretion in a horse is very low, 0 to 0.5%, and in this particular patient it's 16%. It's not a renal failure patient because the fractional excretion of sodium is under 1%. If it was a renal secondary hyperparathyroidism, there would be excessive loss of sodium and a fractional excretion above 1% and probably in the range of 10%. Here's an interesting 3-year-old horse that presents for respiratory difficulty and a diagnosis of sinusitis. It's easy in retrospect to say, hey, wait a minute, there were enlarged maxilla and these other problems, but all these were being referred to the respiratory system, such that on presentation, here's the enlarged maxilla, and then there's the drainage tract of the, quote, sinusitis, and there was a nasal discharge that was associated with it as well. The lesion was biopsied for culture and sensitivity and then submitted for histopath in hopes of either finding the bacteria and/or mycotic infection, and instead the diagnosis was fibrous osteodystrophy, where there's an excessive amount of fibrous tissue producing the enlargement in the maxilla and marked osteoclastic osteolysis, the two hallmark lesions of this disease, along with moderate to marked osteoblastic proliferation along the surface of the osteoid, so that bone coupling and resorption were still intact, but there was an excessive amount of resorption accompanied by fibrous tissue filling the area. This used to be a trabeculum. It used to be a trabeculum of osteoid, and now it's an empty lake filled with osteoclasts that have consumed all the bone that's in there. Radiographic evidence, bone scanning, ultrasound, or other ways to diagnose it. Key, fractional excretion of phosphorus, 8%, and that should be under 0.5%. It's a very easy way, without any ancillary data, to get a quick diagnosis. Very often serum calcium is in reference range. Don't expect to see a low serum calcium, and that's because of the exquisite control of parathyroid hormone on calcium regulation. There can be a relative decrease in calcium and a decrease in ionized calcium, but at every 0.25 milligram change in calcium, it triggers the action of increased parathyroid hormone. That will restabilize calcium, so very often it's within reference range. Phosphorus would be the substance in the serum, along with alkaline phosphatase, that might be increased. So don't depend on calcium, go to fractional excretion of phosphorus, and then of course serum concentrations of parathyroid hormone, if needed, can be used for the diagnosis. Horses don't eat a lot of tuna, but you can produce the same thing in kitty cats that are fed an all-meat diet that are not supplemented adequately with calcium, as there's too much phosphorus in meats. And then here's big head in a goat. It doesn't matter what the species is. Big head in a monkey. This could be related to vitamin D2 in the old world monkeys, and then it would be a form of rickets rather than fibrous osteodystrophy, or big head disease in some wasm type species, iguana, or whatever else. Maxilla just happens to be one of the bones where the lesion reflects itself in most dramatically, but the lesion is going on in all the bones through the body. Those with the highest turnover tend to produce the most dramatic lesions, hence flat bones in the mature individual. Maxilla is a great spot to look for the lesion and produce these facial swellings. Appendicular skeleton, the younger they are, will produce the same thing. Post-mortem, gloves on, not an ante-mortem torture of this poor dog, with big head disease, rubber jaw disease from renal, secondary hyperparathyroidism. The dog actually ends up presenting for respiratory difficulty. That's all that's left of nares, turbinates to breathe through because of the excessive fibrous tissue deposition. To differentiate that condition from rickets, which is due to a deficiency of either vitamin D or phosphorus, but not calcium, it's a failure of mineralization. Vitamin D and phosphorus are more important for mineralization than is calcium, especially 24-25 dihydroxyvitamin D2. The absence of mineralization means that this cartilage will not die, will not form a scaffold for primary spongiosa, and therefore produces tongues of cartilage that protrude down into the metaphysis in these regions. It's a failure of endochondral ossification to occur on these cartilage spicules that are no longer mineralized. Osteochondrosis has a very similar pathogenesis, such that if you look at the lesions in this rib cage, you'll see these irregular tongues of cartilage that protrude from the physeal plate into the metaphysis. And then, much like in fibrous osteodystrophy, there can be metaphyseal flaring and excessive production of woven bone in an attempt to try to repair the lesion. That disease, rickets, in the young growing animal is characterized by lucencies, especially in the physeal regions and metaphyseal regions, and then a decreased overall density. That bone is no longer being mineralized, but there are still adequate amounts of bone so that you do not see increased osteoclastic osteolysis unless there's a secondary calcium problem superimposed, nor the increase in osteoblast. It's osteoid that's no longer being mineralized, it's soft, and in the adult it's referred to as osteomalacia. There's a fine equine steed. The green pasture's here. The donkey's located over here with as much straw loose and in bales as it wants, and this is what's going to end up producing osteoporosis. Fibrous osteodystrophy, calcium-phosphorus imbalance, rickets, vitamin D phosphorus imbalance, osteoporosis, usually a nutritional caloric protein problem, such that there's serous atrophy of fat, visible blood vessels, a uniform physis, even though it undulates, so it doesn't look like rickets, and then holes in the bone, osteoporosis, due to a decreased formation of bone with basal resorption. Normal physis, normal primary spongiosis, early to late stage of the disease, quote, normal physis, but now decreased amounts of bone being produced as well as basal resorption, and then marked, a bone plate that starts to form at the base of the physis, as well as 1-2 spicules of bone that are being produced, and there'd still be resorption that goes on. Send somebody up in the outer space, you produce the same lesion from disuse. There's equine pathology in one slide, busted bones. In fact, we're starting off with the skeletal system and the GI system, and then we could probably end the seminar. Those are the two most important for horses. There's the fracture. The surgeon comes along and repairs it, does a great job, screws, plates, nice bone density. I want you to appreciate that. And then it's a typical horse and it doesn't heal. And then screws start to come out. And so they go in there and they repeat it, and he's loaded with osteomyelitis. There's the old screw holes. The fracture is still not filled in with bone. The old holes, a new plate. So now we're into the disease of months, and now I'll give you the hint. Check out the amount of bone density that we have now compared to the old radiographs. I don't know what month this is, say 6 months. And then the foal goes to stand up one day in the stall, hock, stifle, and a fractured metatarsal bone. And here's the cast line right through here, and you can see the fulcrum that serves so that when it stood up, it shattered the tibia. What the foal's problem now was disuse, osteoporosis, such that there was a decreased amount of cortical bone. When you have muscle atrophy underneath a cast, disuse, you have the same thing forming in the bone. A plate that's too big for the bone, that doesn't let some of the plate permit the bones to bear the weight, will produce the same thing. Disuse, osteoporosis. Very often the patients with osteoporosis have some sort of malnutrition problem, and there are multiple individuals affected. So fibrous osteodystrophy, osteoporosis, multiple individuals, shifting limb lamenesses, fractures that are present. Uniform physis shouldn't be rickets, but we're not going to be too bold. We know what to analyze the feed for rickets, as well as the serum chemistry. And then you can see the fractures that are present in this limb. With fibrous osteodystrophy, the key thing is that parathyroid hormone is binding with the osteoblast, and so there's still production and resorption. With the other two, rickets and especially osteoporosis, there's uncoupling of production and resorption. Mineralized bone is all that the osteoclasts are going to remove. It goes along the surface of the mineralized bone, removing the tissue, and then that's followed by a wave of osteoblasts that lay down unmineralized or blue osteoid. The messengers for this, keep in mind, parathyroid hormone does not have a receptor on the osteoblast. It's a clever link of biology and evolution. The receptor for PTH will be on the osteoblast, and then this has to send out other messengers to communicate with the osteoclast. You can review all these messengers for general pathology, but the key thing is the body wants to link these two processes. And when resorption and formation are unlinked, uncoupled, the disease process will move quickly, and that's the case with fibrous osteodystrophy. Other lesions that we can see, primarily in osteoporosis, but also with lead and various other diseases, are extra white lines that are forming underneath or subjacent to the physis. They'll be called growth retardation lines when associated with excessive parasitism, nutritional problems. Here is one in a canine, epiphysis, physis, metaphyseal sclerosis, this whole white band here because of distemper virus that inhibits the action of osteoblast. Here's that starving donkey with the end of its epiphysis, physis, and then with different waves of nutrition or getting rid of the parasites, you can see the lattice formation of the primary spongiosa that forms plates, and then the marked serous atrophy of fat that's present. Osteoporosis, let's take away the fat first, then the muscle, and while that's going on, there'll be concurrent changes in the bone. They're usually associated with agroceriosis, decreased caloric protein intake. Next in the notes is the wobbler syndrome, or cervical vertebral instability, and in this case, I view this as a form of osteochondrosis. The lesion will be here, there's the physis. The lesion will be out here in the articular facets such that there's malarticulation, slippage, soft tissue buildup, and then impingement upon the vertebral canal and the spinal cord. The lesion of osteochondrosis in the vertebrae is here with excessive amounts of cartilage that build up, and we'll get to that pathogenesis in a minute. Malarticulation, soft tissue that accumulates, encroaches upon the vertebral canal, and then impinges on the spinal cord. Surgeons in Colorado will take out the soft tissue component. The entire vertebral canal is still of a normal diameter and relieve many of the conditions. This is a nice example of the asymmetry of those facets because of osteochondrosis here, such that there'll be malarticulation, movement, and then a corresponding response of soft tissue buildup. The pathogenesis of osteochondrosis has to involve failure of endochondral ossification. It has to involve ischemia of blood vessels in articular cartilage, and there is blood vessels in the AE cartilage of young growing animals. Produces dead plugs of cartilage that don't become mineralized, that can't serve as a scaffold. A little bit of a similar pathogenesis with rickets in that there's a failure of endochondral ossification, failure of mineralization, but in this case it's due to dead plugs of the cartilage rather than a vitamin D phosphorus imbalance. And then there's too much fibrous tissue, too much pink osteoid tissue, so that there is a subjacent sclerosis, an attempt to repair it, and then trauma happens and there'll be a fissure line, fracture line with hemorrhage that develops in that dead plug of cartilage, and now the lesion is osteochondritis dissecans. The itis starts now and the dissecans, or the splitting, has started now. These are the blood vessels. They're dead through here, and now the cartilage chondromes and so forth will die in this region, viable on this side, and dead and dying ones through this region. What that'll produce is a plug of cartilage around those dead vessels, and then that's the accident waiting for the trauma event to happen, and the dissecans, or the fissure, will happen through that particular region. Got to incorporate ischemia into the pathogenesis. And here it is experimentally in swine. The articular epiphyseal cartilage has blood vessels. There they are coming from the outside. And then here it is when they've been surgically interrupted, or it happens spontaneously in this figure, decreased blood vessels, and now this will produce dead areas of the cartilage. This process of chondrification of vessels happens normally, physiologically, and so the adult articular cartilage has no blood vessels. But when these blood vessels die prematurely, pathologically, that'll lead to the condition of osteochondrosis and then these plugs of cartilage. Early on, thick plug, now it's fractured, now it's an osteochondritis dissecans. Osteochondrosis is a major leading cause of degenerative osteoarthropathy. Same location, 10-year-old individual versus a 1-year-old individual. The lesion's now chronic, degenerative osteoarthropathy. In each species, it has a bone it likes to affect more than others, but it can be going on in all the bones or articular cartilage in the body. In the horse, it particularly likes this large ridge on the distal femur, and it'll produce a mild, moderate, or severe cartilage necrosis, erosions, ulcerations, bits and pieces that break loose, severe pain. That's a chronic lesion. By the time these horses present clinically, the lesions are old. Another joint it likes to hit in horses is shoulder. And now this looks like a degenerative osteoarthropathy, except it's in a young, rapidly growing male, characteristically male warm blood, in any of the breeds, but particularly the big growing fast breeds, and those that the owners want to push for rapid growth. Here's one where the entire articular cartilage white is gone, and now you can see the underlying red bone marrow where the articular cartilage is completely worn off. No way to help that individual at that particular juncture. It primarily hits articular cartilage, but it can produce a lesion in physeal cartilage, as you can see through here, and then the subjacent sclerotic response to the lesion. Osteochondrosis, just change species, make it a bird. They change names, of course. Tibial dyschondroplasia. I think we're coming to the end of the first carousel. We need to get ready for the second carousel. The pathogenesis is very much the same thing. Tom turkeys, rapid growth, ischemia through a variety of causes, including fusarium, inability to bear weight, bowed limbs, hadn't been riding a horse all day long, and button ulcers that'll develop. Osteochondrosis is a common condition in horses. Osteopetrosis occurs in other mammals. I'm not aware of it being reported in the horse. Osteochondrosis is associated with overnutrition, pushing those individuals to grow too rapidly such that those blood vessels die prematurely. Osteopetrosis is characterized by a defect in the osteoclast such that bone is not being removed. Again, an uncoupling of formation and resorption. In mammals, the defect resides in the osteoclast, that they're either decreased in normal or have an abnormal function. Bone marrow transplants will correct it. In birds, normal and abnormal, the defect is related to overproduction by osteoblast and is usually viral induced. Osteopetrosis. Common in horses, of course, is laminitis, as represented by the rotation of P3, and now it's actually coming through the bottom of the hoof. That red black line going through right through this region represents the initial stage of the disease, which is hemorrhage and necrosis due to a localized DIC. If you think of that as localized DIC, thrombosis, and dead lamina, it becomes easy to understand why laminitis has so many different causes. If you've got a list of 30 things that can cause DIC systemically, horses have a list of 30 things. Road founder, grass founder, grain founder, water founder that can produce laminitis, localized DIC in this region. The chronic lesion produces the rotation. Now it's not red, but it's white, and it's filled in with hyperkeratosis and epidermal hyperplasia of the laminae covering P3. They look like a ski slope in the chronic condition, and if you'll trim this foot, cut it longitudinally is what we've done, but correctively they'd be doing multiple different shoeings to correct the problem. Underneath the ski slope is where you see the marked rotation and all this excessive amount of hyperkeratosis and even some fibrosis that will occur at this stage. This one looks like it still has some necrosis that's associated with it, and then even resorption now of the distal end of P3. They can rotate to the point where P3 is then visible through the bottom of the hoof, especially common in ponies and so forth. The acute stage, we've pulled off the whole hoof wall now, is associated with that necrosis and hemorrhage. It can involve all the laminae or skip some. This has now resulted in loss of attachment of the hoof, the fingernail, to the underlying sensitive lamina, and it's been pulled off. There's been no rotation at this place. Endotoxemia, colics, a long list for the DIC. Real common in horses is infectious, synoviitis, and arthritis. We should probably think of it as a synoviitis because that's where the process really starts. In horses, it's almost always bacterial, although some less common causes are associated with it. I'm not aware of viruses in horses. Kitty cats and goats, CAE in goats is particularly common. The lesion usually starts in the synovium in these youngsters, and very often the epithelial, if you will, layer of synovium will become necrotic. Neutrophils will then efflux out. The wall often has a mononuclear inflammation, and the neutrophils are rapidly migrating, exiting into the space. When it's a single joint involvement, marked distension, it's more likely to be direct extension than hematogenous, but those are the only two ways they're going to get in there. The direct extension, synoviitis, arthritis cases, tend to be a lot worse, a lot more destruction of the cartilage and the joint than with a hematogenous spread. Red, physis, white. This white line here represents a subchondral or subjacent sclerosis, just like with an osteochondrosis. The bone's not particularly clever. There's only so many ways it can react to injured tissue, and one of it is to make more osteoid, and that'll produce the white color. Hematogenous spread is almost always in the youngsters, and it involves multiple joints. Couldn't be a much worse color than that unless it was fully brown. Opaque, yellow, and it even looks like gas production. Before that stage, the fluid will be semi-clear, serosanguinous, watery, lost its oily texture, and you can see plugs of fibrin inside the joint, fibrinous. The process started in the synovium. The changes that we see are primarily out here in the fluid, and usually there's very little change in the hematogenous infectious arthritis on the articular surface of the cartilage. The fluid is going to lose its dense protein background, and loss of hyaluronic acid will make for watery fluid. The neutrophils will then influx into the lesion, and you may or may not see bacteria that are present. And then as the disease progresses, there'll be less and less of that rich protein hyaluronic acid background. Now it's a watery fluid, and it's filled with bacteria. The neutrophils start to look like monocytes. These are all neutrophils, and they're just dead and dying, so they're swollen, and you can see the staphylococci. If it's hematogenous infectious arthritis, it's not just in the joints. It'll produce a meningitis, it'll produce an ophthalmitis, it'll produce lesions in the liver, lung, certainly not all of those locations. Renal tissue is a great spot for actinobacillosis and foals. So it's not just confined to the synovium and the joint spaces, and about 1/3 of the foals that have an infectious arthritis synoviitis will also have osteomyelitis in this very characteristic location subjacent to the physis. The location there is due to this vascular histologic organization such that there are patent capillary venous spaces subjacent to the physis, and that is on top of the physis, but it's the same principle, so that lesions develop in the epiphysis or in the metaphysis due to this unique circulation, the patent arterial venous spaces. We used to say it was due to loops and bends in those capillaries in that location, but now we know it's due to patent areas. So then those bacteria can flow out and they'll lodge in the location. Very characteristically, in electrophoresis, what you'll see is albumin and then no gamma globulins. Failure of passive transfer is key to the pathogenesis of this disease. In the ruminants, it's almost always due to decreased intake. In horses, they usually do in fact consume colostrum in under 12 hours, but it's an inadequate colostrum that results in failure of passive transfer. Another key part in the pathogenesis is that they may have a lesion elsewhere. That's diarrhea on the ends of the hock joints on the tail from salmonella, one of the worst organisms you can culture, and was associated with a much worse prognosis is salmonella. And there's the markedly distended joint, but all the joints were distended in this yearling. And here's the characteristic location: epiphysis, physis, metaphysis, and then subjacent to the epiphysis is the start of the osteomyolysis. Mild, moderate, now it's gone through, now it's present on both sides of the physis. A real early case where the white areas of the neutrophils and the bacteria have just started in this metacarpal bone. And then in an advanced case, they didn't know this foal had bone lesions. They knew it had an infectious synoviitis, and about 1/3 of the foals will have bone lesions. And I love this photo because it demonstrates P1, P2, P3. P1 has 2 growth plates, there, and so there's 2 abscesses. P2 has 1 growth plate, so there's 1. P3 has 1 growth plate, so there's 1. Very characteristically located subjacent to that physeal plate. Usually they don't break through the articular cartilage. Look how severe this lesion is in destroying and removing bone. I'll guarantee you this is all dead necrotic bone in the formation of a sequestrum, but they don't usually come through the articular surface. But they certainly can come through the articular surface, very often by breaking out right at the junction of the physis with the periosteum, and then go out into the joint space. This one looks like it's also eroding through right here. This is a real chronic osteomyelitis in the foal. It can be located in other bones. Here's one in the vertebral column. You can still see the physes here, and then characteristically it's going to locate underneath those. And so here's the osteomyelitis in which there's been collapse of the vertebrae, and now compression so that the infection is located here and now out into the vertebral canal, impinge on the spinal cord, and produce spinal cord signs in that foal. One of the consequences of osteomyelitis, and that's a poor prognostic finding in these foals when present, many of them can be detected radiographically. One of the sequelae of this is a sequestrum with its involucrum isolating that piece of dead bone. When the sequestrum, the piece of dead bone, is that large, it's going to require surgical removal. Radiographically, you can see how little of that sequestrum is still left with mineral. The acids have leached out much of that sequestrum so that it looks like a big plug here. Radiographically, it looks like it's a large space because essentially that's soft tissue at this point. Once the mineral's gone, the osteomyelitis infection through here, that piece is going to have to be removed surgically. The sequestrum, involucrum that isolates it, if that gets too large, the body can't remove it, it serves as a nidus of foreign material, inflammation associated with it, and continued processes. You can also have an infectious arthritis through direct extension, as I showed you in multiple slides ago, and here's one that's gone through at the coronet, produced a tremendous amount of granulation tissue on the external surface, and green black bone is dead. Direct extension osteomyelitis situations tend to be worse than the hematogenous. And you can see how this lesion's penetrated all the way through. P3 is essentially gone, necrotic, and P2 is somewhere located in between that sea of black, green, and white material. It can be located in other bones. Here's the hyoid bone in a horse with an osteomyelitis secondary to guttural pouch problems. Here it is extending bilaterally in a horse with guttural pouch empyema, and that would serve as a direct extension. Other areas you can see infection, but now it's a bursitis, would be fistulous withers and poleval. Closer view of that shows that they've tried to drain it previously, excise some of the tissue, and you can see the suture areas through here. These can be difficult lesions to ever correct. Surgical debridement for some of these is one of their considerations. The list of etiologies includes onchocerca. The use of ivermectin certainly decreases that. And then, interestingly to me, is a fairly low number, but a survey of horses that covered some period of time. You may have a difficult time seeing it in this particular photograph, but in the old days we used to list Brucella abortus as a major cause of fistulous withers and poleval. More recently, strep zoo, strep equi is the most common organism that's cultured. But because of the possible zoonosis, those horses' titers and/or cultures should be set up to check for Brucella abortus. But in this day and age, poleval, draining purulent fetid material is more commonly associated with streptococcal organisms than it is onchocerca or Brucella abortus, but you should still keep that in mind. Navicular bone. Here's a bursitis of the navicular bursa. Navicular disease is characterized clinically by a horse with a pointing limb lameness, quarter horse, barrel racer, occupational hazard of spinning on the front feet, is actually a disease that has multiple lesions that can produce it. What we typically think of is expansion of these holes or spaces, nutrient foramens, from normal to the disease state, where it then shows up radiographically as navicular disease. That's one of the lesions. Then why are there holes inside those bones? Because there's a bursitis, an itis, and if there's inflammation, plasma cells and lymphocytes, then they'll produce IL-2, various cytokines and interleukins, or prostaglandin E2 that stimulate the bone resorption. You're not going to have holes in that bone without some mechanism, and the messengers for that would be the inflammatory cells from the bursitis stimulating PGE2 or IL-2. You can also see the lesion with fractures, ischemic necrosis, and excessive trauma. So it's not just due to those patent holes. Degenerative joint disease in the equine industry then goes by a variety of names: ringbone, splint, spavin, and those are all just common names for degenerative joint disease. And here's a low ringbone, P2, in which all the articular cartilage is gone. the bone's visible. Here's one where it's almost down. In fact, it is down to the underlying, quote, metaphysis, the bone with trabecularly cancellous bone underneath that surface. And then the response is a marked amount of woven bone all around the outside of that P2. Splints are characterized by a control and then the affected individual where there's an excessive amount of woven bone. Distal end of metacarpal or metatarsal bone. This is actually a high ring bone, degenerative joint disease, rather than a splint, and it's located at the end of one of the metacarpal bones or metatarsal bones right before P1 would start, versus the splints represent fusion, fine, and then fusion and an excessive amount of woven bone over the surface. Very common to have a high medial splint in almost all youngsters. When it involves this area, it's usually due to trauma. When there's fractures at the end of the splint bone, they usually require removal. Fusion, as in this case, usually produces soundness. It's the movement of the bone that produces lameness, not the woven bone that's present over the surface. Horses can get a necrotizing myositis that essentially serves just like a blackleg lesion, most commonly located in the necks of horses and due to Clostridium injection and spring vaccines. And it'll result in massive gaseous production, hemorrhage, and necrosis with minimal to no inflammation. Usually in the neck, can involve other areas, and very often vaccine related. Endurance horses, draft horses that sit on their backs too long, all can be associated with some form of rhabdomyolysis. Prolonged anesthesia for the draft horse. The endurance horse with anaerobic glycolysis inside the muscles will be one of the conditions that starts it off. And when it happens, these individuals are in tremendous pain. They're not going to move. This guy's holding his head by resting it on the bar of the stall. In the muscles in that horse is massive myocytolysis. Decent muscle fiber, destruction. This one's gone on long enough that there's even the start of some regeneration in terms of those spindle cells that are present. The myoglobin is going to leak out and produce myoglobinuria, as exemplified by this test tube with brown colored urine. It'll start to look like Pepsi. And the differential for that includes intravascular hemolysis, hemoglobinuria, myoglobinuria, or just hematuria. This is a gross path course, but somebody better know how to do this differentiation of these conditions. One of the things I always like to say, much since I'm part of the club, I guess I can say it, is clinical pathologists lie. You can take that message home, but the bottom line is we rarely measure what we tell you we're measuring. So here's a dipstick that supposedly measures blood, hemoglobin, and it doesn't. It just measures an oxidation reaction. So that anything that stimulates that oxidation reaction, hemoglobin produces the positive blue color. Therefore myoglobin, therefore plants, bacteria, these other substances all can produce the blue color that looks as if it was blood. Of course, we can do special tests, ammonium sulfate precipitation, which takes out the hemoglobin but not the myoglobin, as a way to differentiate it. And if that doesn't work, just ask the lab to give you a more sophisticated test, and they can do that as well. There's immunoelectrophoresis, spectrophotometry, and we can measure it. Now, the problem, of course, with rhabdomyolysis, capture myopathy, Monday morning disease, any of those, is renal tubular necrosis. Tubules that are fine, tubules that are entirely necrotic, some that are somewhere in between. Depending on the number of these that are destroyed, will predict whether or not that individual dies or recovers. Of course, in the renal system, those tubules that are patent, when that toxin is coming through, will be the ones that have the lesions. The hope is that there's enough of these that are skipped, that there'll be remaining nephrons that can regenerate and compensate for the loss of those that are totally necrotic. Those that are somewhere in between, the key factor is whether or not they had a basement membrane, and if so, they'll regenerate. The usual outcome of these cases is euthanasia. muscle enzymes are characteristically increased, and CPK is not just 10,000, it's over 1 million in this horse. In large animals, in particular horses, unless that CPK is over 50,000, I really don't care. It's just a little too sensitive. And then you can see how they went through some of these tests we just talked about to prove that it was myoglobin. Tying up, just one of the nicknames, much like the horse folks like to use for a bunch of their problems. And then I want you to see this horse with a CPK of 80,000, whoops, no, all the way up to almost 1 million on day 5, and the outcome was recovered. It's not uniform that all these horses are in fact going to die with this problem. Lucite is our horse. Day 1 of an endurance ride, day 2 of an endurance ride, and then the end of the endurance ride, and here's 2 of our other horses. And Lucite urinated yellow-brown on this day, and of course scared us. We didn't know what the values were, but I just took blood samples. What I want you to appreciate is her urea nitrogen never changes significantly. That's no change, and in fact is lower than these 2 guys over here. Not all animals, not all horses with rhabdomyolysis will produce renal failure. My bias is the myoglobin is not the nephrotoxin. There's adequate work to show hemoglobin and myoglobin are not the nephrotoxins. There's other small molecular weight compounds that are excreted that are the toxins. My hunch is that in some of these horses that do fine in endurance races, even with brown urine and high CPKs, but is just doing terrifically, don't release whatever that nephrotoxin is. What we definitely know is that there's multiple types of rhabdomyolysis, exertional rhabdomyoglobin in horses. Glycogen myopathy is one of those that are characterized. Dietary control and rapid recovery is one of the keys to indicate whether these guys are going to get into trouble. And our horse quickly recovered, and as you can see in this horse, it's 20,000 at the end of the ride in 1 hour. It's already down to 5,000 16 hours later. This thing is cleared rapidly. As long as the condition is no longer active, it decreases. If that started anaerobic glycolysis, swelling of the muscles, lactic acid production, these values would continue to increase. So that's a major indicator. One of the other key problems these endurance horses get into is thumps. And if you see an exam question, relate it to calcium. But usually the calcium concentration is not that abnormal, and what it's more commonly related to in my mind is hypochloremia. In fact, the #1 electrolyte abnormality in horses in endurance rides is hypochloremia, and it is due to the excessive amount of sweating. With that, they'll very often get a decrease in the potassium concentration as well. But most people associate thumps or diaphragmatic flutters with hypocalcemia. List it. That's fine. Consider it. Test for it. But I think what you'll find more often is it's the chloride that's abnormal. It can produce rhabdomyolysis in the heart muscle, and therefore renal failure or cardiac problems can produce fatalities. And you can also see in foals in which there's vitamin E, selenium deficient areas, a white muscle disease, much like you do in ruminants, but nowhere near as frequent. Neurogenic muscle atrophy, Sweeney, lesions to the supraspinatus nerve can produce marked atrophy of the shoulder muscles, prominent bony protuberances, and then it just depends which nerve was traumatized. Here's a femoral nerve paralysis such that the quadriceps is a bowl or a dish due to the atrophied muscle. Nerve's going to regenerate about 1 millimeter a day. This one's never going to come back, and there won't be muscle regeneration. Prior to the muscle atrophy, this looks just fine, but you shouldn't be able to do that in a normal guy. So depending on whether or not the nerve regenerates, there can be muscle atrophy that'll then start to show up in the semi-mem and semi-10 of this horse. Hypertrophic osteopathy produces massive, marked, or mild proliferation of periosteal new bone, and it skips articular surfaces in P3 because there's no periosteum in these 2 locations. So this is periosteal new bone formation that can fill in the entire bone areas, clinically makes these swellings, and typically it tends to be in the metaphyseal region rather than in the diaphyseal region. So we'll see more on the ends of long bones than in this area. It can also be in axial skeletons, but we'll see more of the lesions in the appendicular skeleton. Usually associate this with some space-occupying lesion in the thorax, but it certainly doesn't have to be. And in horses, one of the lesions that's associated with hypertrophic osteopathy is ovarian tumors, and in particular, dysgerminomas. And that's what that last horse with hypertrophic osteopathy had. Neurogenic and vasogenic stimuli, even hyperestrogenism, are associated with it. I don't know which one's proven. In dogs, coccidioidomycosis and hepatozoonosis would be differentials that you don't need to use in horses. And if it's a disease of antiquity, periosteo new bone formation can also be associated with fluoride toxicity, especially those animals that graze pastures. Well, this is the end of this carousel. Especially horses that graze pastures adjacent to smelting camps. These guys never get tying up. Heck, they never move fast enough. And that's one of our competitive rides, and those mules are pretty good competitors. Bone tumors in the horse are a little bit different from the small animals, and especially those tumors that are located on the head, oral cavity area. Squamous cell carcinoma is a differential, maybe fibrosarcoma. Very typically, they'll get these oddball lesions, fibrous osseous dysplasia. They can get osteomas located here as well, produce a large growth, but very seldom do they invade very deeply. Surgical excision, trimming will usually take care of these. Osseous dysplasia, fibrous dysplasia are some of the terms that are used, and they'll produce a small amount of bone that are associated with them, or they can be dense and osteomas. That's what they invent microscopes for. Here's one of the incisor teeth. Once they start to invade tissue, once they start to get into sinuses, then it's more likely to be a squamous cell carcinoma. Those are the most common in the head of the horse, but these will usually involve oral cavity and then make it up into sinuses and turbinates at some point. In this particular horse, it was located in the parotid region. Local invasion, muscles in the area is the thumb rule, but they can metastasize. That white horse had squamous cell carcinomas that made it all through the pleural cavity, pericardial surface, and had pulmonary mets as well. So they can go systemic. Cytologically or histologically, very characteristic, huge, large squamous cells that have sufficient keratinization and intercellular bridging to justify the diagnosis of squamous cell carcinoma. That's the number one nucleated cell that you associate with fluids that have squamous cell carcinomas. The best place to look in the fluids are way out at the feathered edge. Squamous cell carcinomas in the stomach are fairly common in old horses. Maybe I shouldn't say fairly common, they're just one of the more common tumors that we locate there, and can be diagnosed from fluid examination, abdominal centesis. Femoral bone with red marrow. There's only one reason for tissues to be red, some sort of heme ring with iron, and that's either hemoglobin or myoglobin. That's it. And we often don't look at bone marrows of horses, but we'll see red marrow stop somewhere in the diaphysis. This one's gone way too long. That's some sort of hyperplasia. It doesn't have to be the red cell line, it could be the white cell line. Here's one that forms a discrete area of red here, another one here, and another one over here. Now we're starting to think that that's not just hyperplasia, but neoplasia. And in fact, this horse had a myeloma. Those are white blood cells, but the lesion's red. There's only one reason for it to be red, the heme ring, so it's congested. Lymphomas can be red, myelomas can be red. It represents expansion of the tumor, blood vessels, congestion, and they turn a red color. There's the patient's electrophoresis, and it shows a monoclonal gammopathy in the serum and in the urine. Here's the control over here, and then this represents the area of albumin, and there's the gamma globulins. So myelomas are described in horses, almost all of them can be. This is what we need when we go to Ames, Iowa, double brain power. And what it starts me off into is anomalies. When you find one anomaly, you find two brains, two heads, you might be done looking, or you can continue to look. And so here's palatal schisis mild, and here's cleft palate severe. When you find one defect, go look for another defect. And a place to look for these folks would be eyes, cardiovascular, musculoskeletal. This starts us off into the gastrointestinal system. We'll work our way through the palates, and the dental arcade. So here's a wave mouth, irregular dental attrition that's produced this wave contour in the oral cavity, and then some of those can lead to food impaction, abscesses, and sinusitis. Sinusitis, purulent, what looks like in this cross-sectional view, we're behind where the impacted tooth was, and this tooth is fine, but you can see the abscess is still present in the sinus region. You have to be careful. You might start to think that this is an enumeration or failure to erupt of a tooth here, but the molars in the horse have very long curved regions, and it's easy to cut those in such a way that you think it's an impacted tooth or something that failed to erupt. Here's one taken back where there's no continuity between the erupted portion below and the retained portion here, and sinuses are nice and clean. You can see the same thing in a preparation. This side shows the eruption through here, and then this long curvature, all part of the same tooth. If you cut at a different angle, there'll be this space through here. This base or root will look like it's a retained area or the abnormality. In fact, it's just part of tooth eruption in the horse. Long curving molars. And then what you can end up with is an impacted sinusitis, as in this case, inspissated material that's not going to drain out of that sinus, and or a guttural pouch, empyema, bilateral, barely opened up more over here, dry inspissated material. When it gets like this, they'll use the term chondroid for inspissated pus. Moving into the tongue, a large area of ulcer, sharply delineated, going all the way across. Can be trauma, can be tooth, can be a rope, anything that got caught over that surface to strangulate it. One of the diseases to think of for ulcerations in that area were vesicular stomatitis and cantharidin, or the blister beetle toxicity. Here's a cute one in a cow tongue. I just threw it in there, ganglionema, the tongue worm of the cow, and you can see the tracts migrating through. Esophageal muscular hypertrophy is fairly common in horses. What's characteristic of all horses is that the distal esophagus tends to be thicker than the proximal esophagus, and you need to make sure it's just not a normal physiological event the first time you look at it. This one looks like it's too thick through this particular region, and then this is a no-brainer. There's marked muscular hypertrophy, usually not associated with any clinical problems. Massive muscular hypertrophy, well beyond the physiological changes that you see in the distal esophagus of the horse. If the horse was choked, it'd be pretty easy to associate this with the lesion, but rarely does that cause clinical problems. Comparison of normal to an ulcerated esophagitis. White areas, a hyperkeratosis, and that's usually all what that is, but it can be candida on that surface, and then the ulcers that are in between. Some form of trauma to that surface. Acids can do that. Mild regurgitation, pretty darn rare in the horse. Stomach tubes, candida would lead to it. Choke usually doesn't produce that lesion. Usually it produces a circular and then sharply demarcated band with a plug of food in that choked region. Plugs removed. Here's the initial line, necrosis, scar, thickening, and now contraction, cicature in that particular region. Sharp line of demarcation, dilation, fibrosis, scar tissue, hyperkeratosis, the white area over the surface. So every time you see white in the tongue and the esophagus, don't immediately think it's candida. And then here's one that's fully necrotic. Sometimes you can find these with the food bolus next to them still located. Necrotic area, an early one that doesn't have any of the proliferative changes, and then the food can exit out into the adjacent muscle. Gastric ulcers, dime a dozen in horses, maybe decreasing with ivermectin, but I don't think so. Margo plicatus, junction of glandular, squamous. Most commonly you see them over the squamous surface, yellow discoloration, ulcers, and then massive hyperkeratosis if you look at those microscopically. Sometimes some glandular metaplasia. can cover a large area of the squamous portion associated with a variety of problems, including gastrophilus. When they're small, irregular, bloody, those are the ones I like to think of, the non-steroidal rather than the large ulcers, but the non-steroidals can produce large ulceration as well. And then those that are associated with big blood clots, those are the ones to investigate subjation to the clot for some sort of cancer, squamous cell carcinoma. Ruptured stomachs in the horse are almost always along the greater curvature. They can happen post-mortem, and so the key to thing is to distinguish those from ante-mortem versus post-mortem rupture. Hemorrhage, ante-mortem, curling back of the mucosa, ante-mortem ruptures. Hemorrhage through here, curling back of the mucosa, a splitting of the tissue layers, all supports ante-mortem. Once the horse vomits, puts out food particles through the nose, that stomach has ruptured and they'll have a short amount of time to live. Here's one associated with a marked amount of hemorrhage as well. They'll usually die before there's much in the way of fibrin formation in the abdominal cavity. In fact, abdominal synthesis is most commonly characterized by a normal total white cell count because the patient dies or is euthanized before there's a opportunity for neutrophils to influx into the abdominal cavity. This is acute gastric dilatation in a dog with volvulus and splenic engorgement. In horses, we tend to call everything their own diseases. In Europe, they'll call gastric dilatation in the horse grass sickness, and then you'll read that we don't get grass sickness in this country. We do. They'll say that gastric dilatation in the horse, 50% are associated with an obstruction distally. That's true. In my mind, acute gastric dilatation in the dog, in the horse, in the cow with abomasal displacement, in primates, guinea pigs, man, on and on. It's all the same thing. We don't need to change names just because we switch species. And it's true, the horse does not develop a volvulus, nor do all the dogs with acute gastric dilatation, nor do people, nor do primates. It's very rare in primates, non-human primates and humans, to develop a twist of the stomach. So I view acute gastric dilatation in the horse the same entity as it is in those other species. No reason to change names. Margo plicatus, brood pouch nodule, Drossia or Habronema, hole, cut surface, hole, tract, parasites, granulation tissue, verminous, gastritis, gastropathy, acute gastrophilus, intestinalis, nasalis. The names go backwards from where they're located. The closer they are to the esophagus, intestinalis, the closer they are to the pylorus. Nasalis, trip to Hawaii, washer and dryer, you can't stop there. Also have a lesion over here, up close and personal. And then here's a trichostrongylus lesion, this cobblestone appearance over the mucosal surface. That's trichostrongylus axii. Same thing here, makes plaques. Here's the line of demarcation about in here where this area is too thick and proliferative, up close and personal. Same thing here. There are the plaques, and then this corrugated surface, trichostrongylus axii. Hyperplasia, metaplasia can start to form glands. Strongylus edentatus tends to produce granulomas in the abdominal wall. Clearly visible here. Yellow fat's part of being an anorectic horse, an increase in the bilirubin concentration. On cut surface, they'll look a lot like a lipoma with necrotic centers, mineralization, gray-green, abdominal wall through here, the yellow fat you just saw, a little muscle, strongylus edentatus granulomas, and they may not be as large and bulging and easy to see in the last one, and you have to squint. Again, the use of the modern-day anthelmintics has greatly decreased their presence. The large bowel, colon, cecum, small colon, sacculated, green-gray is never good. Something's gone wrong with the base of the cecum. Ruptured base of the ceca can happen spontaneously. I don't think it's due to these guys, Anoplocephala perfoliata, but late-stage pregnancy, Anoplocephala perfoliata are associated with rupture of the base of the cecum in horses. When you have any sort of angry-looking changes on the mucosal surface, go find another cause besides Anoplocephala. Small strongyles produce tiny little lesions that you better squint at to see. Little ulcerations and or the parasites that are still located in these circular pockets, and this can produce, much like in goats, considerable anemia and hypoproteinemia associated with it. Unthrifty looking pot-bellied horse, shavings, ugly nose, action photo please, and then there he is defecated into the dumpster with ascarids coming out through the feces. You have to have your camera at the right place at the right time to catch these action photos, and there's polyuria and probably polydipsia associated with it. All depends where you are with your camera at the right time, folks. And so there's the feces from that youngster, and usually you see ascarids in young horses, and then you can also see it in the old horses. These can be associated with intussusceptions in various locations. I won't get into the antihelminthics and whether or not different doses stimulate some of those intussusceptions or not. Two sides of mesentery, so you know you're located at the ilium. Small little red or red-black lesions, hemomelasma ilii, sometimes with a sharp line of demarcation, fibrosis that's associated with it over here, a no great shakes lesion, hemosiderin, yellow hematoidin, and various stages of hemorrhage that can be associated with those, with or without eosinophils. I don't know what they're due to, probably not parasites. And then a dime a dozen, horses are going to get impactions. I don't know if this is pelvic, sternal. Actually, I think it's supposed to be small colon, but gosh, that really looks big. And then there's the basketball. Grapefruit impaction that had moved through the system. You can find all sorts of sizes and varieties and shapes. They become true liths in stone formation, circular patterns. Very often they can be associated with other things that the horse has ingested, rubber fencing, burlap sacks, something that starts off as the nidus that this material can then start to adhere to and grow from. This was the burlap sack, and you could find the fibers all through here, and then the smaller concretions, the little oysters that are going to start to grow off of the surface. And then you can look for the pearl in the center. There's the wire, nail, whatever it was that was ingested, and then the large stone that formed all around it. And you can see the concentric rings, much like a tree, the little particle that's located here. Sometimes even on radiographs of these, you can see that concentric or laminated pattern as it starts to form multiple layers. Yeah, the key thing is that it obstructed outflow. And then thromboembolic colic is almost a disease of antiquity because of the use of ivermectin. But here's the lovely sharp line of demarcation, viable, dead, and involving a large portion of the large bowel associated with aorta, craniomesenteric artery, thromboembolic colic, the verminous arteritis, and eventual occlusion of small vessels, release of vasoactive amines such that collateral circulations don't form, thromboemboli. We'll still see this at the university in the junior surgery ponies that aren't taken care of. Go to the sales and pick those up. But in the most horse owners, because of ivermectin and so forth, that's a disease of antiquity. No great shakes. Old horse, lipoma, just hanging there, but ready to flip, curl around that loop of bowel and then produce strangulation. Dead, necrotic, dying, viable. These actually have a good prognosis for the outcome. Don't necessarily involve a large portion, but can. Here's one that's just a small area. Surgeons like to find these. Almost always the horse is old, approaching its 20s. Geldings more commonly than mares, but that's just probably because there's more of those guys out there. And then if you cut through them, natural surface, cut surface, very often it's different degrees of mineralization and or necrosis that you see. I have no idea if that's really cancer, lipoma of fat cells. It sure is a mass made up of fat. I don't view them as neoplastic, but you guys can argue about that. Small bowel, and then sharp line of demarcation, dead purple strangulated small intestine. That could be a lipoma that's located at the base. It could be nephrosplenic. It could be a rent in the mesentery that they go through. Rents in the mesentery of all the various types of small intestinal strangulation would carry the worst prognosis. Not exactly sure why. And then you get boa constrictors, massive amounts. These are usually a volvulus that occurs at the base of the mesenteric attachment and just involves multiple loops of intestine. Boy, you sure wouldn't want to see that at surgery. I don't even like to see those bulge out at me at necropsy. Purple loops of small intestine are almost always through a mesenteric, epiploic, nephrosplenic. Rare that you can ever produce dead large bowel through those type of spaces. Inguinal hernias, testicles, strangulated loops of small intestine, and then when you get to this, incredible, massive, dead, infarcted large bowel, those aren't going to go through tiny little rents. Those are true torsions, twisting on the longitudinal axis, and then they'll just involve various amounts, if not the entire large intestine. Hard to believe the surgeons couldn't save this one, huh? And they're just physical obstructions. They're all going to rupture eventually. That's not quite true, but when they do rupture, the key thing is, was it antemortem or postmortem, and how these particles are adhered, and whether there's fibrin will usually help you make that prediction. And you'll find the hole at some point, and then the dead necrotic material around it. When it's viable, dead, small area, these are great ones to consider that there was pressure necrosis from some enterolith, cholelith that may have been located in there. This one has a somewhat jagged edge to it. I don't know what anterior enteritis is, or if they're still talking about it. We used to talk about these mild hemorrhagic fibrinous tags on the surface of the duodenum. It seemed to be one of those clinical enigmas that we couldn't support much with from the path standpoint. Two sides of the mesentery, and therefore you know this is the ileum, and you can get distal muscular hypertrophy of the ileum, much like there's muscular hypertrophy of the distal portion of the esophagus. The changes in the mucosa are usually just a relative change due to the muscle compression here. Much smaller percentage of horses have this lesion, and it usually doesn't produce clinical problems as well. The Clostridial enteridides in the youngsters will produce dead surfaces of the bowel with or without mats of bacteria, inflammation and necrosis located in deeper regions. The more thrombi that I see in the lesion, the more likely it's a salmonella type of infection. Micro, a little bit larger thrombi, massive neutrophil exudation that goes through there. Severe neutropenia, leukopenia in the horse, more likely to be salmonella than the clostridials. Cryptosporidium is rare in foals, common in the calves, inflammation or almost absence of inflammation, and small dots 2 to 6 microns, circular, out in the surface. Microvillous portions characterize cryptosporidium. If you get lucky, you get to see micro or macro gametes along with the trophozoites that dot that brush border, and then everybody's got an electron micrograph that shows them attached in that microvillous region, and then you know that they're actually intracellular in their location, despite what looks like they're just covering the surface. That's not a big deal in foals. Immunosuppressed Arab foals, you might get a chance to see it. Fresh material, and then this is common, rhodococcus enteritis that produces discrete granulomas with various size ulcers in the middle, covering a marked infiltration of macrophages, constipated, packed with those organisms, with or without associated pulmonary lesions. Lymphoid hyperplasia in the intestinal tract is fairly uncommon in the horse. The further distal you go, the more likely you are to see it. Neorickettsia in dogs is one of the lesions you can associate that with. In the pharynx, pharyngeal mucosa, it's associated with equine herpes. Granulomatous enteritis, lymphosarcoma. Now that's common in horses. That's worth talking about. And it produces a skinny horse. So here's an old, no, it's not that old. I think it was only 5 or 6 year old racehorse that they couldn't keep weight on. Do a complete workup, eliminate renal, liver, get to the guts, and eventually you're going to need a biopsy. Normal mucosa here, granulomatous enteritis or lymphoma. And in this case, it's granulomatous enteritis on this side. Blunting and fusion of the villi, and an infiltrate that's predominantly mononuclear with some giant cells that are scattered through there. A relatively low number of these. You can find acid-fast organisms in the lesion and or on culture. The efficient resorption of fluid often means that these horses do not have diarrhea. They can produce normal feces or cow flop, manure type of feces, but usually not diarrhea. Associate diarrhea with salmonella, clostridial, endotoxemias, but not the granulomatous enteritis. They're skinny as a rail because they can't absorb glucose, carbohydrates, or protein, and then it doesn't matter what graph I show you up here. It would be a flat line intake compared to normals of carbohydrates, sugars, or proteins. And then the mucosal surface looks like Johne's disease. Thick mucosa, and of course it can be mild, moderate, or severe, and then this one is a thick mucosa over the surface, and it can produce discrete lesions on the serosa. Now, this is why they invented microscopes. This could be rhodococcus, it could be granulomatous enteritis, and it could be lymphoma. And I don't know which slide is which. This one with its red color, discrete lesion, sharp demarcation, I would have predicted had a rhodococcus or the granulomatous enteritis, lymphoma. This one has no ulcers in the middle, solid, solid. This one has an ulcer in the middle, and this one's lymphoma. Those lesions can look very similar grossly. Don't get too cocky. And they can look similar microscopically if it's a endoscopic biopsy. They can be predominantly lymphocytic, but with different markers and looking at enough lesions, you can sort your way through it. Here's that thickened, proliferative, rugose pattern, and this one was also a lymphoma. Lymphoma, granulomatous enteritis, and you know how to work up the cases. This was a granulomatous enteritis, marked thickening of the submucosa as well as the mucosa, makes this hose pipe, turgid appearance. Lymphadenopathy, big lymph nodes, goes with both diseases, lymphoma and granulomatous enteritis. But the histologic organization of those two should be quite different. One would retain its organization, granulomatous enteritis, but have hyperplasia, and then the lymphoma destroys, abrogates normal architecture. Mucosal surface, lymphoma that's infiltrated its way through the various layers and would end up transmural. Granulomatous enteritis does not have to stop at muscularis mucosa and can in fact go through the submucosa. Petechia, ecchymoses, endotoxemia, shock, colic, all those go together in horses. Can go with strangulation and endotoxemia, or can go with salmonellosis, gram-negatives, and endotoxemia. When it looks like there's a lesion underneath the serosal surface, when it's got discolorations and mottling, and especially when it involves the large bowel, then start to think of infectious agents. And here's a salmonellosis that has produced diphtheritic membranes over the surface, discrete dead areas that can be from the thromboemboli or intensification of the infection in those particular regions. Button ulcers or ulceration would be a characteristic of salmonellosis. You could see a similar pattern, especially if this bulged forward with Rhodococcus equi. And then on cut surfaces, here's the serosal surface, thin mucosa, and then this dead necrotic demarcated line through here of the surface of an salmonellosis. If you're going to get cultures from these, at least 4 or 5, and you better include the biliary tree. Sharp lines of demarcation I like better for salmonellosis and the vasculitis that's associated with it. Another cause of vasculitis in the horse is mycotic, and the ruminant as well. And if the mucosa is not thickened, if it's just red, then it may just be petechian ecchymosis associated with endotoxemia. I'd prefer not to culture these unless that's all that I had to work with. But if red is significant, then the mucosa is thick, there's fibrin, there's necrosis, there's something else. Otherwise, red is no great shakes. It just caught your eye. Massive amounts of edema are what we associate with colitis X, or whatever this shock-like mechanism is in the horses. I know Chuck Wimberly produced it when he was trying to produce antibodies to platelets, and could produce this massive sort of mucosa about the second or third time he exposed some horses to the antibody he was producing. We need help with non-salmonella colitis, non-Potomac fever colitis situations in the horse. We don't know all the pathogens that can produce some of these small intestinal and colonic lesions in the horse. Salmonella, Potomac fever produces such a mild lesion and is not an easy disease to diagnose serologically or on tissue sections. Non-steroidals can produce ulceration, especially in the right ventral colon, much like they can in the stomach. Parasites, but I predict that there's other bugs that are waiting to be discovered that produce these acute diarrheal syndromes, and there's more to negative cultures when you do 4 or 5 in horses with a negative salmonella than to say, oh, it was just culture technique or exposure to antibiotics. There's other bugs that we don't know names for yet. And then here's larger ulcerations associated with non-steroidals in a horse. The differentiation of neoplasia from abdominal abscesses is not easy to do ante-mortem, but post-mortem, you just open up the mass and pus. Green-gray material pores or sticks to that surface of an abdominal abscess. Despite what we think of for horses, some of these abdominal abscesses can be septic and quite large and purulent fluid. As long as they don't leak into the peritoneal cavity, the horse can carry those for quite a while. Foreign body, bastard strangles, various ways to produce those. Here's a large one. I think this one was in the perirectal area. The rectum sits retroperitoneally for part of it. A hole that forms in that region can end up with abscess formation. This isn't perirectal. This is in the abdominal cavity. Yellow, gray areas of necrosis. And then underneath this particular lesion was the pancreas. There's saponification of fats, pancreas, and dead, almost sequestered tissue through this region. Pancreatitis is rare in the horse. I don't know how you'd ever diagnose it when those guys are still alive. Parasitically, Strongylus equinus is one that they associate with that. But it's just a rare oddball lesion, especially compared to this. Margo plicatus, somebody's probe, squamous portion, glandular portion, ulcerated surface. That's too big. There's a mass underneath it. That's squamous cell carcinoma. And you can diagnose a fair number of these, more than half, 3/4, 80% of those ante-mortem. And the horse is not one you'd want to buy. If it sits in that horse long enough, there'll be massive emaciation. It doesn't matter which angle you look at the horse at, they're skinny. Tumor, cachexia. Characteristically, these can have hypercalcemia and hypophosphatemia associated with it. And one of your differentials for the skinny horse and those electrolyte abnormalities are chronic renal failure. Look at this poor guy. Squamous cell carcinoma, renal failure was present in that horse. They can metastasize to the liver through implantation or vasogenic means, and then make tracks on cut surfaces or cover natural surfaces. This one actually made it into the myocardial tissue, and that's what all these foci represent through here, or implantation metastases that cover the surface of the diaphragm, producing a carcinomatosis all through the abdominal cavity. Increased calcium, decreased phosphorus in horses. Squamous, Bots, There'd be a great photograph and go for squamous cell carcinoma, and you'd be wrong. Squamous portion, I don't know, that's pretty darn close, but this is lymphoma. And here it is. I don't know if it's exactly the same horse or just another one. That stomach, large amounts of the intestine loops and spleen were adhered to this area. Thought for sure it was going to be a squamous cell carcinoma, and it's a lymphoma. Horses have been reported to also have LGLs, large granular lymphomas, that can be detected on abdominal synthesis or inside these masses. Natural killer type cells, I guess is the best nomenclature. Trip to Hawaii and washer and dryer. Histochemically, they'll stain with PTAH, a blue color. I don't think there's a difference between a globular leukocyte and a large granular lymphocyte, and we'll let some researchers sort through and find out if there really is any difference between those. You can find in the literature that some people, in fact, just call them large granulated tumors because they're not sure of what their origin is. Okay, that's GI Tract 101, and now we're into Endocrinology 101. In the horse, thyroid gland, follicular adenomas, small, are common in older horses and are clinically silent and insignificant. If you don't know what the organ is, repro or endocrine, and especially if it's red and bloody, thyroid gland is a good one to consider. And then here's a larger thyroid follicular adenoma in the horse that are clinically silent. No hypothyroidism associated with it. No hyperthyroidism associated with it. If it's hyperthyroidism from one gland connected by an isthmus that we always talk about bilateral glands in, then it's a uniform enlargement of the entire gland. Usually you see these in the younger aged horse, bilateral hyperplasia and hypertrophy, a goitrogenic response with iodine excess or deficiency. And in horses, very often it's an iodine excess, supplementations, kelps, horse people, wacko, giving them way too much of different things if a little bit helps. In the ruminants, it's usually a deficiency and produce marked goiter. My buddy over in New Zealand says all that they have to do is leave the iodine out of the pastures at a certain stage in the gestation, and 80% of their lamb crop, goat crop will be lost. Hypothyroidism, goiter, does occur in foals and is associated with prolonged gestation, northwest United States and Canada. We started off the seminar with slip tendons, crooked limbs, and that was part of the condition in these foals. They have musculoskeletal problems, prolonged gestation, and then they've got a lower jaw that wants to stick out beyond the upper jaw. They've got all these problems that they can associate with them clinically that speak to some signs of immaturity, even though it's a prolonged gestation. And they'll have delayed ossification. That's good bone. Good hock, that's delayed ossification. Patencies, failure of ossification centers to form cartilage that has not converted through endochondral ossification into bone, and on its cut surface you can see these carpal bones that are entirely cartilage or delayed ossification centers that are now going to try to form epiphyseal bone. And if you take those foals and you try to do a TSH response test, much like you would in any animal to confirm hypothyroidism, flatline. Here's some normal foals where you measure T3 or T4 post-injection of TSH, and you see a nice rise over 3 to 4 hours, versus the affected foals have a flatline response. Interestingly, these guys do not usually have macroscopic goiter. There was no enlargement of the foal's throat when I showed that to you. We know in horses they can get big glands from our weanlings and yearlings, but they do have microscopic lesions of goiter where there's hypertrophy and hyperplasia and papillary projections of the entire gland. Not as severe as you can see in some of those ruminants with massive hypertrophy that have consumed all the colloid and just left vacuoles residing behind. They don't know the etiology for it. They've looked at a lot of different compounds that produce goiter, thyroid hypertrophy in other species, and other than to associate it with some different types of pastures and nitrates and excessive growth, they don't know. So stay tuned. Parathyroid hypertrophy, hyperplasia, or tumors, call me collect from any place in the world if you find one in a horse. They are reported, they do occur, but I'll take your phone call. They're rare, and it's almost impossible to find the parathyroid glands in a horse, and you know this isn't a horse, because they're not attached to the thyroid. They sit up at the carotid bifurcation, and they're very difficult to locate. Dogs and kitty cats, easy to find parathyroid. The other species, tough. And pigs and horses, almost impossible. Don't look around here. It's just lucky if you find the parathyroid, the medial one that's attached to the thyroid gland. You need to go cranial. And the same thing with Kirsteiner cyst, or cyst of the duct that connected thymus and parathyroid gland. A dime a dozen in dogs. I don't know, 75% of dogs should have those microscopically. You'll see those occasionally in horse thyroids, and if you're lucky to ever get the parathyroid, you might see one there as well, but those are uncommon lesions. Nodular adrenocortical hyperplasia, much like seen in the canine, does occur in horse adrenal glands, and if you look for those, you'll find those. They're also clinically silent, no great shakes. Horses do develop pheochromocytomas. Dr. Gelberg's done some of this work. I've forgotten if they're mostly norepi or epinephrine producing, but red, bloody lesions in the center of the adrenal gland, pheochromocytomas, usually clinically silent with the characteristic microvasculature, small trabeculae that dissect their way through the lesion, forming those microlobules, white or red, and then if you put potassium dichromate Zankers type stains over the surface and you're living right that day, they stain very nicely, and you can just carry your clinical suspicion, gross path to suspicion a little bit further and get it in the category of pheochromocytoma. Adrenocortical hemorrhage, congestion, and necrosis is common in the adrenal glands of horses, especially those with colic that die of endotoxemia. The majority of horses with colic, with those problems, if you look at the adrenal glands, you'll see this to the point it's expanded and compressed upon the medulla. It starts to look like this is hypertrophy. It's due to the massive hemorrhage and edema that's present inside that gland, to the point where sometimes it's even hard to cut a histological section as it just falls apart from hemorrhage and necrosis. I'm not sure if it produces electrolyte disturbances as it does in small animals, medulla, cortex, massive hemorrhage, and now you can see white fluff balls. This actually represents a septicemia in a foal with actinobacillosis equili. It can produce a Waterhouse-Friedrichsen type syndrome lesion in youngsters, much like it does in foals with an E. coli septicemia. But in the old guys, and then we'll go to another carousel, in the older individuals, it's associated with colic. Hemorrhage, with or without necrosis, is a characteristic lesion in the adrenal cortex of these horses with colic. Can go into the medullary tissue as well. When it involves zona glomerulosa is when I think it can start to produce electrolyte disturbances, and some of those electrolyte disturbances we definitely see in the horses with colic, whether it's due to a deficiency in aldosterone or all the problems are going in the GI tract. I don't think anybody has looked at those in particular. In the youngsters, an aborted or a neonatal foal that has discrete lesions like this, that's more commonly associated with an embolic shower, actinobacillosis equili, or the inclusions of herpes virus. Herpetic inclusions in the horse associated with equine rhinopneumonitis, in the bovine associated with IBR, in the dog with infectious canine herpes virus. It's just a great place to look for those lesions. The hemorrhage and necrosis and infarction that can occur in the youngsters or in the horses with colic, produces lovely color patterns. In the foals, this will definitely produce a Waterhouse-Friderichsen type of syndrome and electrolyte disturbances. Well, I threw this one in there just for the heck of it to see if I could get you to bite on melanoma, since this is a horse, but in fact, it's a cow. And you know, that's about all you need to do. Change species and you change your diagnosis. Tuck tail and run. Adrenal, cow, and you'd probably call that melanosis. Adrenal, sheep, melanosis. Make that adrenal in a horse, and you'd go for melanoma. I want you to hold that thought, because I'm not so sure melanomas in a horse really are omas. Many of them may be osis. Don't want to buy this horse either. Old, swayback, curly hair coat, pot belly, quote, Cushing's disease or pituitary tumor in old horses. They'll produce long, woolly, shaggy hair coats in the horse, not in the handler, and will retain that hair coat in the summer months. Very often they've got a pituitary tumor, and then the pathogenesis gets a little bit different from the story in dogs. Rather than producing excessive amounts of ACTH, these usually produce intermediate pre-pro-clip melanotonin type products that stimulate the syndrome, and compression into the thalamus and hypothalamus are what result in retention of hair coats, problems in the appetite center, etc. They're looked at, I think, as benign lesions, but they can be large, expansile. Maybe it's benign because it's in such an old horse, and they can be associated with hemorrhage, fibrosis, but they usually don't ever invade vessels or up into the parenchyma. They can, but they'll have considerable nuclear atypia, large karyomegalic nuclei, sometimes with cytoplasmic invaginations inside to the nucleus, multinucleation. So despite their histologic, cytologic appearance of some degrees of anaplasia, they still behave in a benign fashion. Expansile growth rather than invasive. And some of them can be pretty monomorphic and fit better into the definition of a benign tumor. I'm about getting tired of this two-headed calf with two brains and two cleft palates, but once you find one anomaly, you look for another anomaly. And so that starts us off into the cardiovascular system, and the number one anomaly for the trip to Hawaii, the washer and dryer in foals, is interventricular septal defect. Same thing in bovines. Dogs, it ought to be aortic stenosis or PDA. In large animals, change it to an interventricular septal defect associated with right ventricular and left ventricular hypertrophy to the point where they're about uniform thickness in the walls and no PDA. In a while, we'll look at the same area with a tetralogy of Fallot. And then you'll have a small hole, sometimes with marked endocardial elastosis, coronary vessel, small interventricular. Subjacent to the aorta is the best place to look for that lesion, or you got a marked hole, massive. Notice that there's not as much endocardial elastosis in this individual, maybe because it didn't live as long. It looks like perhaps an aneurysm that's formed up here in the aorta as well from all the turbulence. And then here's an intraatrial septal defect that was so large it essentially produced a common chamber between the right side and the left side. Interventricular septal first, maybe, looks like another lesion right there, maybe intraatrial in some degree of frequency in the foals as well. Intraatrial septal defects, especially common in kitty cats. Now you start to combine the interventricular septal defect along with pulmonic stenosis and overriding aorta and right ventricular hypertrophy, and you produce tetralogy of Fallot, which is actually about the second or third most common anomaly that you see in foals. Hold on to your hats. Interventricular septal defect, most common anomaly in foals. Tetralogy of Fallot, the most common cardiovascular anomaly associated with cyanosis, polycythemia. These guys are anoxic. Some people say without a patent ductus arteriosus, they won't even live that long. Blood comes through the right side, tries to exit out through the pulmonary artery and can't, so gets pushed over to the left side, and now unoxygenated blood is going out through the aorta over through the rest of the body. This is when, if you had a PDA, look how that would shunt some blood over here, then oxygenate it to come back through over the left side and at least give us a chance to get some oxygenated blood out through the aorta. So these guys tend to be real cyanotic, and they can be polycythemic associated with it. Aortas that come out the right side of the heart don't live long. Non-aerated, minimally aerated lungs, aorta coming out to the right side, transposition of aorta and pulmonary artery, compatible with life in utero, not compatible with life after birth. Lymphatic anomalies on the surface of the heart, you'll see those in some youngsters, no great shakes. Second lesion, serous atrophy of fat. You should see a pad of fat in the coronary groove, and the blood vessels should not be that prominent. So half point for the lymphatic anomaly, no points if you blew that one and you didn't see the serous atrophy of fat. Serous atrophy of fat in that skinny little donkey that I showed you earlier, where it's a gelatinous red color and then very prominent blood vessels that you can see over the surface. Must have some degree of mesothelial hypertrophy, hyperplasia, to see these plaques on the aorta and pulmonary artery as well. Serous atrophy of fat occurs any place there's fat, including the metaphysis, prominent blood vessels, and then this lesion, osteoporosis. Even though it doesn't have the big holes, we should have bone coming down through here in the metaphysis, and it's gone. We're right up to the physeal plate. Yeah, we've seen the donkey, so we'll go on by. Oh yeah, the other lesion that that donkey could have, should have, is aortitis, and associated with Strongylus vulgaris larvae, worms, that have a characteristic migration in the craniomesenteric artery, but also subjacent to the semilunar valves, and produce an aortitis or subvalvular granulomas. Mineralization, white crinkling material, endocardial surface, sometime extending down into the myocardial surface, associated with some calcium phosphorus imbalance, such that there's soft tissue mineralization. Vitamin D toxicosis from cestrum, tricetum, not in horses, rat bait, modern generation, are now loaded with vitamin D, will produce massive soft tissue. Go to Florida where some of these plants grow, Bogota, I don't know, got to get south of Washington, D.C., and you can start to see hypervitaminosis D. You can also see it in the horses with renal failure. They'll produce soft tissue mineralization, nowhere as near as frequently as carnivores, but you can see some. And then you start into valvular endocarditis, fever of undetermined origin, leukocytosis, bits and pieces that break loose. The pathogenesis of endocarditis should involve a lesion in the endocardium, interventricular septal defect, something that traumatized the surface of the endocardium. You don't just spontaneously get bacteria sticking to that endocardial surface, they'll get washed by. In human medicine, there's different streptococci that can uniquely attach to that endocardium, but in veterinary medicine, if you look, usually there's some explanation why the endocarditis got started. Trauma to the surface, fibrin that adheres, then there's a place for the bacteria to lodge. Characteristically, the aorta, the endocarditis, is loosely attached, and these are bits and pieces that are just ready to break loose and then shower through the rest of the body and produce micro abscesses. A lot of this blue is bacteria. And then depending where it's located, they'll plug pulmonary vessels and or produce hemorrhage, thrombosis associated with embolic showers. Necrosis in the myocardium can be associated with mineralization or look just like mineralization, or can be seen with various coccidiostats or other myocardial toxins. Monensin would be one, chemotherapy in the small animals would be one, and in horses we can see Zenker's necrosis or myocardial necrosis with exertional rhabdomyolysis. If there's massive amounts of mineralization, then vitamin E selenium would be another consideration. This is a horse with exertional rhabdomyolysis. Blood vessels further down the track, aorta, craniomesenteric, no-brainer, strongylus vulgaris, and this lesion also is an aneurysm. Inside the aneurysm, corrugated surface is the endarteritis, and then attached to the endarteritis are all the fibro, thromboemboli, proliferative, fibrinonecrotic neutrophils, usually not bacteria, that are then going to shower through this region and result in thromboembolic colic. Sharp line of demarcation, jagged, dead, green, gray, pink, and viable. Disease of antiquity after the use of ivermectin, but still see it in those donkeys or ill-kept ponies and so forth. Thromboemboli quadrification in horses is idiopathic. In horses is strongylus vulgaris. Don't really know what causes it, but much like in the small animals, no femoral pulse, weakness in the hind limbs can be associated with saddle thrombi. In small animals, amyloidosis and so forth, but not in large animals. Rupture of the aorta where the forceps are here, aorta here, semilunar valves here, post-racing, post-breeding, idiopathic. What is it? Sweet pea, copper deficiencies, latherism, abnormal collagen would be another set of etiologies you can associate with it, but most commonly idiopathic. Here's a cleaned up specimen, and if they got labels, even easier to find the hole. In real life, it's just massive cardiac tamponade that in real life is even harder to see. Here's the costochondral junctions, pericardium, a window's cut out of the pericardium, and this is massive cardiac tamponade in a horse. Lungs here, liver here, and it's a currant jelly and a chicken fat clot that's in that pericardium. The underlying lesion, ruptured aorta. So do the necropsy, and usually you'll figure those out. Here's a saddle thrombus quadrification in a dog. And in dogs, you associate this lesion with glomerular lesions, something to result in decrease in antithrombin 3. In horses, it's rarely ever associated with amyloidosis, but in horses, you can produce those lesions with a glomerulonephritis, and then you'd go through that same antithrombin 3 story and increased platelet hypersensitivity associated with decreased albumin. All part of forming pulmonary thrombi with an underlying glomerular lesion. Dogs, amyloid or GN. Horses, GN. Jugular vein even with valves. Isn't that pretty? And then here's thrombosis, vasculitis, phlebitis associated with jugging, intravascular injections, dirty needles, or periveneal injections of caustic substances, butazolidine. Chylothorax is a disease of kitty cats. Get it out of here. What are you doing with it? Abdominal cavity of a foal, and that was the fluid that was taken out. And those are the results for it. Yellow, white, one-day-old filly, abdominal distension, distress. There's what was seen through it. What are your recommendations? Neutrophils are characteristic of chylothorax, chyloabdomen. The number one nucleated cell that you'll see with those conditions is neutrophils, not lymphocytes and macrophages. The way to diagnose it is to measure triglycerides and cholesterol concurrently in fluid and serum and compare the values. Or just measure it in the fluid. And if you've got a massive amount of triglyceride compared to cholesterol, diagnose chylous. Or if you've got a massive amount in the fluid compared to the serum, diagnose chylous effusion. So that's the key to diagnosing chylothorax, chyloabdomen, and then I don't care what the species is that you see it. The chyo is what contains the triglycerides, the cells are what contain cholesterol. And so in that little filly, it was a lymphadenitis. We didn't figure out what caused it. Massive chylous effusion, but it turned out to be fine. That's not the case in small animals. Chylous effusions are usually associated with a poor prognosis. One of the things you'll see with repeated drainage is a decrease in sodium and an increase in potassium, such that you'll produce sodium-potassium ratios, low sodium and high potassium, with pleural drainages of chylous effusions and pleurides in the horse that look like Addisonians or hypoadrenocorticism. Good hind limb, bad hind limb, lymphangitis. Lots of fancy terms in addition to wires or strangulations that can produce this. Glanders, pseudoglanders, Farcy-type syndrome, plug lymphatics and inflammation, rhodococcus, streptococcus. There's other ways to produce that inflammation and lymphangitis other than some of those foreign or uncommon diseases that previously we've associated with it. Horses that develop peripheral edema stocking up and edema along the belly wall, those are all more characteristic locations of edema that develop in heart failure in horses. Peripheral edema, skin, muscle, along the subcutis, then is ascites. Pretty uncommon to see ascites in the horses with cardiovascular failure. But no matter what the species, there's only 4 ways to form edema. Increased hydrostatic pressure, heart failure. Decreased colloidal because of low albumin for one of these systems that have a lesion in them, or increased pressure in pitting edema is just an edema in which with digital pressure, a pit or hole can be left behind. Typically in a horse, edema is going to be located peripherally, stocking up in the limbs, end of the mandible, along the belly wall, and it's rare that fluid accumulates in abdominal or pleural cavity associated with heart failure. It can happen sometimes. I don't know exactly what this is, but here's the aorta, semilunar valves, massive aortitis. The first thing that you need to think of with this is strongylus vulgaris. If this was in a cow, for some strange reason they're associated, especially if it's mineralization, with Johne's disease. Strongylus vulgaris is the first one to think of. A lot of people say we don't see it much today in ivermectin, and I tend to agree with them. But if you want to see it, don't clean up the blood vessel. Leave it a little bloody and then smear your hand over that surface, and then you'll start to see just some tracks, the laminar flow, the way the aorta or other vessels are organized. But that's sometimes when you can also see the very early or very mild tracks left by strongylus vulgaris. So it's one of the few times where you don't want to get the lesion too clean. Sometimes if the area's been hosed off, I'll add a little blood, smear it over the surface, and if you're lucky you can see tracks just like that one in the photograph. Lovely photograph. Isn't that of the jugular vein? There really are valves that are located inside of veins. I think I threw that one in there just because it's so great. My wife and I have been married for 20-some years, and we follow the Phyllis Diller philosophy of life. Just stay up and fight. Never go to bed angry. Okay, let's switch over to the renal system. Another big system for the horse, and we'll fly through it. Surface of the kidney, red, bloody mass, cysts. Sure, it could be hemangioma, hemangiosarcoma, give me the rest of the necropsy, but very often those cysts will fill with red bloody fluid, or sometimes they'll just fill with urine. Mild in the last one, severe in this horse kidney, polycystic renal disease, hereditary in West Highland White Terriers. Don't know anything about familial tendencies in horses, a really rare common of failure of the renal system. Pulpy kidney disease in ruminants also occurs in horses, and it can be regional or segmental autolysis, just more advanced here than here, and associated with prolonged postmortem intervals, hyperglycemia, etc. Real nephrosis is characterized by segmental lesions, but now there's karyorrhexis, pycnosis, slough cells, and there may or may not be some neutrophilic or other cells that infiltrate in. If these animals die peracutely in the nephrotic stage, there'll be no inflammatory cells that accompany it. compounds that do it in the horse include gentamicin. And if you look at the articles that talk about confounding situations that enhance this substance's nephrotoxicity, they'll talk about poor circulation, and I'll give them that one, and they'll talk about sepsis. Why the heck are we giving them the gentamicin if it's not for sepsis? So that's a crazy thought to say that this would be contraindicated during sepsis. That's just when you want to give the stuff, but it is associated with nephrotoxicity. If they live through the initial insult because there was basement membrane that was preserved or tubules that were not affected that then go through hypertrophy and hyperplasia, then one of the responses will be fibrosis in the interstitium. Essentially, you end up with tubulointerstitial diseases that go together, and then some tubules that will never return to normal function. In the horse, I think it's pretty typical with their chronic lesions, whether they're glomerular or tubular in origin, that you can end up with a fair number of oxalate crystals. Polarized light, birefringent, light up like Christmas trees. They say horses are not susceptible to oxalosis. I'm not sure about that, but definitely horses will accumulate endogenous oxalate crystals associated with chronic renal failure. You can also see those if you'll polarize the renal sections from pups with progressive familial renal dysplasia. A lesion that definitely occurs in horses, medullary crest, is renal medullary crest necrosis. Green is bad, that's dead and necrotic. And so here's papillary necrosis in most of the other species, but since the horse doesn't have papillae, they call it renal medullary crest necrosis, and it's associated with three things. One, it's just ischemia. No matter what the papillary and medullary crest necrosis, it's ischemia. And then there's various ways to produce it. In the horse, it's most commonly done with some butazolidine-like product that results in changes in prostaglandin production and synthesis such that there's a localized ischemia. Then you must superimpose decreased water intake and decreased food intake. These guys drinking, eating enough like our endurance horses, no problem. But you add those other compounders and then you'll produce that problem. Another way to produce tubular necrosis is hemoglobin or myoglobin. Neither one of those may be the parent compound that makes the toxin, but regardless, there's clearly nephrosis, tubular degeneration and necrosis, and renal failure associated with these. So don't be so clever to think that there's not renal problems with those. And then in the horse, for intravascular hemolysis, the number one you're going to pick is red maple. Now I'm going to set you up. Which leaf is toxic? Who's red maple and who's silver maple? Sure, pick that one, it's red. Bzz, no credit. Here's the red maple over here. It's got a more gradual or shallow scallop to it, so color is not the indicator. You got a deeper scallop that's located over here, and definitely red maple and silver maple are the same colors at different times of the year. So color isn't a way to sort it out. There's the red maple with the wider and shallower scallop, and here's the deep notch that you get with silver maples that are non-toxic. Oaks will also do it in horses. You think of it more commonly in cattle, but oak, I'm not sure if the oak buds will work, but acorns will, and yet our pony used to eat acorns all the time and never had any trouble. So there's got to be something unique in certain individuals. And myocytolysis from exertional rhabdomyolysis can certainly end up with pigment. That's hemoglobin, myoglobin, or bilirubin when I see that pigment, and then tubular necrosis. These cells are now starting to try to cover and stream across and protect that basement membrane. Only one left on this entire side, maybe another one there, but if they can cover basement membrane, that tubule will regenerate. Dead, pycnotic, whatever the toxin is, there's clearly a nephrosis associated with it. The non-renal lesions associated with renal failure in a horse are nowhere near as frequent, dramatic, or extensive as in carnivores. But you can produce soft tissue mineralization in the myocardium and on the endocardial surface in horses with chronic renal failure. Vasculitis This is a lovely photograph, isn't it? Here's an intact side of the blood vessel, no problems here, and then that's true fibrinoid necrosis. When it involves the whole vessel, I get a little bit scared. Am I looking at some artifact? But when I can see abnormalities on one side and not on the other, and then obviously the necrosis and neutrophils that come with it, it's clear cut. Uremic vasculitis in horses with renal failure occurs, again, for whatever the reason, not as frequent as in the carnivores. Hydronephrosis due to some obstruction is best exemplified in this bovine kidney, and you won't believe where this lesion is located. It's not just obstruction here, but it's calculi that were all through the ureters and then up into the pelvic region. Hydronephrosis occurs, not that frequent. Nice infarct in this horse kidney, white infarct, red line of demarcation, still must be recent, no contraction over that surface, localized coagulation necrosis, infarct, hemorrhagic infarcts in a bovine kidney, anemic infarcts, so these are younger, these have been leached out of the hemoglobin, and then a nice jagged line that covers that area and marks the demarcation between dead and viable. Nice demarcation, sharp, discrete red zone through this area. And rarely do they ever produce renal failure. Multiple red foci and cut surface of this kidney could be interpreted as infarcts, but no great shakes even if they are. The key lesion is the multiple white foci with or without a red rim that goes around those that represents an embolic shower, embolic glomerulonephritis in a young foal with actinobacillosis equili that lodge in glomerular capillaries or in interstitial capillaries, and there's the bacterial emboli rearing and looking like a horse's head inside that glomerulus. From that point, the neutrophils will exude out and then expand from circular foci into large coalescing areas that can occupy large chunks of the parenchyma in a histologic section. And then from the natural surface, that area right there is going to be yellow or white with a red rim border. There's the yellow surface on cut, and then on natural surface, yellow as well. And now we've gone from small embolic showers to the formation of microabscesses. And then once you hit 75% of the renal parenchyma that's not functioning properly, they'll be into renal failure. Gram-negative organisms, in my mind, with a Brown and Bren or any of the gram stains, if you just have a hint that they're rust-colored and at least not blue, it's gram-negative. That stain works great for gram-positive, but it doesn't work as easily on gram-negatives. Tripto Y, washer and dryer, Paul Stromberg will never get this answer right. Horse kidney and big tumor growing out this side and again over here. If I set you up well enough for this one, Paul, another horse kidney, and look at this marked expansion and bulging areas that protrude out to you in this non-neoplastic lesion. Here's granulomatous nephritis due to the organism I can pronounce, Micronema deletrix, and I guess the new name is Halocephalus deletrix. I mean, these lesions really, to me, look like cancers, but that parasite, more common in Europe than the United States, can produce CNS lesions and granulomas in the kidney that look a lot like tumors or tumor-like lesions. End-stage renal disease in the horse can produce small kidneys or big kidneys, and kidneys that get lobulated and start to look like bovine kidneys. In this particular kidney, it can be hard to tell whether the initial insult was tubular interstitial or was in glomeruli. There'll be a plethora, a whole group of lesions that go from glomeruli to interstitium to tubules, and these are the ones that very often you'll find the oxalate crystals in if you'll look. You can have membranoproliferative glomerulonephritis, and I know your notes talk about a membranous nephritis, and it's rare, a membranous glomerulonephritis, but the first case of true anti-GBM in animals was described in a horse. So normally we think of small animals with those diseases, but it can be in the horse. And then we'll hit various stages of end-stage glomerular lesions where they're sclerotic and adhered to the capsule, or there's dilation of Bowman's space and just small remnant tufts that are adhered behind. These are the ones to look for oxalate crystals. I think in all species, but seems to be a little bit more common in the horse. End-stage renal disease polarized some of these, and I believe these are endogenous in their origin and not from any exogenous compounds. Little overexposed lung with a thrombus, pulmonary thrombosis in a horse. Endocarditis was a differential, but we mentioned earlier another one was glomerulonephritis. So this guy actually had as his major problem a severe fibrinopurulent pleuritis and probably pneumonia, perhaps secondary to that chronic low-grade respiratory infection. It developed an immune-mediated glomerulonephritis and then pulmonary thrombosis that you're going to tell me is due to a decrease in antithrombin 3 such that we lose inhibition of the coagulation cascade, so it proceeds uninhibited and can form thrombi. And since AT3 is smaller than albumin, it leaks out when we're losing albumin and producing hypoalbuminemia. In addition, there's platelet hypersensitivity. Here's another end-stage shrunken kidney with a nodular surface. You can also see this with vitamin K toxicity in the horse. As far as I know, it's unique to the horse. I don't know if we see it in the other species. We can have compensatory hypertrophy to try to compensate for lesions in different locations. This is actually a mild stage of pyelonephritis through here with interstitial nephritis and expansion of this cortical tissue or the coloration through this area. And interstitial nephritis or any of those other chronic renal failures in a horse very typically produces a severe, emaciated horse, prominent bony protuberances. It looked like that other horse with gastric squamous cell carcinoma. And here's Paul Stromberg when he was a young man down at Texas and had a hint of gray hair that was left behind. And no matter what the equidae, one of the characteristic features in about a third of the horses with renal failure is hypercalcemia and hypophosphatemia. That is really unique. Small animals can develop hypercalcemia with renal failure, but they never develop hypophosphatemia. We focus on calcium so much, but there's some interesting changes with phosphorus. Oh yeah, that's a little small. Here's a group of horses where they experimentally did nephrectomy and produced a hypercalcemia and hypophosphatemia. So it doesn't happen to just one individual. It's a pretty characteristic response. About a third of the horses will have it. Blister beetles, alfalfa, southwest. Usually we don't see it over here on the east coast so much. Cantharidin, crimper that crushes the alfalfa stems will trap these bugs and release the toxin. Non-crimping preparation and the bugs will just leave while the hay is drying. The result is marked hemorrhages, ulcerations, erosions on mucosal surfaces including urinary bladder, esophagus, tongue, and throughout the GI tract. Hard to confirm the diagnosis unless you can find historical information of feeding alfalfa and you find the bugs. It takes a liter of urine to get the cantharidin toxin out of it. Characteristic ClinPath changes are low calcium and low magnesium, along with inability to concentrate their urine, and then the hemorrhage that's associated with the petechia and ecchymosis. A sorghum cystitis is really secondary to a sorghum grass-induced CNS lesion, decreased innervation, apnea of the bladder, and accumulation of calcium carbonate such that it can make this sludge of urine obstruct the urine outflow. So sorghum cystitis is not the sorghum that causes any inflammation of the urinary bladder. It's secondary to bladder atony due to the spinal cord lesion induced by, I guess, the nitroprussides or whatever else are in there. This is a true ulcerative cystitis in the horse. It's rare. I don't think there's any entity so that you can package up a group of 50 of these and say, hey, here's what characterizes it. One of your differentials for this would be transitional cell carcinoma, which is very rare in horses, but it would still produce that ulcerated surface, or squamous cell carcinoma. In the horse, bladder tumors are more commonly associated with squamous cell carcinoma. That's the number one, and especially throughout the urethral tract. And in dogs, it's usually transitional cell carcinoma in the bladder and the urethra. Horses are a little bit different in their pattern, but in either way, it's uncommon in horses. Kidney, discrete area, should be an abscess, pretty white, sharply demarcated, the only one, and that's a renal adenoma. Papillary would be its subclassification. They're rare, but you can find benign ones, and you can have malignant ones that are present as well. This is actually a nephroblastoma and or a teratoma that occurred in the renal cortex and expanded into this region as well. Renal tumors are rare in the horse. Then in these little youngsters, this disease is common, and it's a ruptured urinary bladder, and they're almost always in males. Associated with parturition 3 to 5 days ago, and there didn't have to be any trouble with the parturition, and then the foal gradually got sick over a couple days. Male foals, rapid parturition, compress on a narrow urethra, the bladder ruptures, and it always ruptures in a characteristic location, and you're going to tell me where. Typically, these foals have low serum sodium and high potassium. They got a sodium-potassium ratio like an Addisonian, like a foal with a septicemia. And the key to the diagnosis will be to take abdominal fluid and compare it to serum fluid for urea nitrogen or for creatinine. And if the belly fluid creatinine is greater than the serum, if the belly fluid urea nitrogen is greater than the serum, it supports a diagnosis of uroabdomen. The foals usually don't have any underlying lesion in the bladder. This would be a ruminant with urolithiasis, necrosis, and rupture. You don't diagnose it from abdominal synthesis. There's nothing characteristic about it to tell you that it's urine, whoops, until you get to these spermatids in a ram that had that same problem. Characteristically, they rupture dorsally because that's the ventral musculature arrangement in foals, and that's the dorsal. So the idea is it's easier with the expanded bladder for those muscle layers to split apart and then explode out. Once the bladder ruptures, it releases fluid with low sodium but high potassium and high creatinine, so that the high creatinine in the peritoneal fluid will diffuse across and will eventually produce azotemia. 48 hours or so. So as long as the belly fluid creatinine is greater than the serum creatinine, that'll be the key to the diagnosis. And then they produce characteristically low serum sodiums and chlorides because they're exiting this way, and high potassium because they are in high concentrations in the bladder and are headed back into the blood. So uroabdomen is a differential 4. Sodium-potassium ratio is less than that, as is just straight renal failure in any species, as is Waterhouse-Friderichsen in foals and calves, Addisonian situation, and then this really fits for small animals. Chylothorax, pleurothorax in the horse with drainage will produce that same sort of ratio in serum, potassium, and sodium as well. Okay, liver disease. Number one liver disease I think of for horses is serum hepatitis, Tyler's disease, that produces a massive hepatic necrosis, acute, that results in a flabby liver. Small, massive necrosis. Once you start to see a corrugated surface, white areas, that speaks for some other liver lesion, not just necrosis and atrophy of the underlying parenchyma, but true inflammation and fibrosis. White livers, fatty liver occurs in horses, but primarily just the mini horses and mini ponies. And here's one that you'd think it was a cow or a cat. Pink remaining hepatocytes and massive fatty infiltration throughout the liver. And that will produce liver failure. Hepatic congestion, chronic passive congestion in this liver in a horse with cardiovascular failure, corrugated surface, and some fibrosis occurs, but nowhere near as frequently as it does in small animals. And of course, then when present, they'll have centrilobular degeneration, congestion, and even necrosis that will occur, but rare to get ascites. No great shakes. Almost all the older horses have on their diaphragmatic surface of the liver fibrous tags, and your notes talk about fancy names. for fibrosis, hepatosis, hepatica, whatever they call these things, but insignificant. Some people have associated them with parasitism, chronic peritonitis. I don't know what produces those. You can also have abscesses in the liver, especially in the foals, from an ascending omphalophleboides that follows blood vessels or out in the parenchyma and makes these discrete white areas of abscess tissue. Some of the organisms that you can associate it with in horses would be actinobacillosis equili and a septicemia, much like in the kidney. Equine herpes will produce inclusions inside the hepatocytes adjacent to the areas of necrosis. And then, of course, Tizer's disease would be one of those that classically produces some areas of necrosis and then relatively mild inflammation that packs along the outside. And then do a Warthren starry type of stain to visualize the organisms. And then for the trip to Hawaii, the washer and dryer, that lesion in an older horse with massive anemia, granulomatous, non-suppurative hepatitis is one of the lesions associated with EIA in horses. And in fact, when Dr. Coggins and Norcross were experimentally producing this lesion, that was one of the characteristic changes of EIA. Abnormal parasite migrations, ascarids and so forth, can produce discrete white areas and fibrosis, and there can be vascular thrombosis associated with various vascular entities, including vasculitis and mycotic infection. That's just what this looks like, but this is a colilith that hasn't quite formed into stones. And then marked fibrosis, biliary fibrosis that's associated with that lesion. There's the huge stone in the bile duct. There's the marked fibrosis that's associated with it. So coliliths occur in horses just like they do in the other species. And here's the colilith, but here's a cute little change that you should be aware of. Anorexia in the horse is associated with mild to marked increases in bilirubin, so that in this horse that hasn't eaten for 5 days, it's got a total bilirubin greater than the horse with the colilith that was producing hepatoencephalopathy from the marked hyperammoniemia that was present. Key to the distinction of these diseases is anorexic-induced hyperbilirubinemia is almost always indirect with very little conjugated bilirubin. If you'll split those two, you can differentiate the anorexia-associated hyperbilirubinemia from that associated with cholestasis. One of your thumb rules is that once the conjugated form of bilirubin is greater than 25 or 1/3 of the total, and then I don't care how high the total is, it might only be 5 or 6. Regardless of that total concentration, once it's over that ratio, then it does speak for cholestasis in a horse. That's a big difference from the other species. Hemolysis can also produce this renal hemoglobinuric nephrosis that we talked about. It can be associated with hepatic lesions secondary to the anoxia, and we can reverse the process. Liver failure producing a bilirubin-stained renal tissue and a bilirubinemic nephrosis that's associated with it. Photosensitization in the light pigmented horses from crotalaria and various other hepatotoxins also occurs, primarily in the southwest. A disease of antiquity, prima paste, that they used to give these foals. We thought had some mycotoxin in it that produced massive hepatic necrosis and failure in foals, but with tremendous biliary hyperplasia, such that we thought that the foals must be getting something in utero rather than just in their first 5 days of life, but massive amounts of iron that was present in that primapase product produced this syndrome, and of course now they've discontinued it. Autolysis of the liver that can produce some interesting changes that look a lot like it's going to be necrosis, but if it follows along biliary trees and vascular trees and nowhere else, watch out, you're not going to get just fooled by autolysis. And those ascarids during migration are leaving the ship, and you can see those entering the biliary tree and the biliary duct as well. Just some oddities that you get. And pseudomelanosis over the surface of the liver, cut surface, pigment stops at a certain point, setting up against the GI tract, sulfas, hemoglobin, pseudomelanosis, staining those color patterns. Pretty terrible photograph to start us off in the respiratory system of horses, in which there's massive sinusitis that destroyed the turbinates that you can see on this side that are gone from here, and then purulent material that's literally just flowing outside of those sinuses. Polyps, nasal polyps inside the nares of a horse can be idiopathic. Polyps, polypoid lesions, or they can be associated with Rhinosporidium seberi, as in this polyp, which the blue is inflammation and all of the circles represent the organisms. In fact, a large part of the lesion can be more organisms than it is inflammation, and until these rupture and release some of their contents, usually there's not much inflammation in the adjacent tissue. But once they give birth and release the trophozoites into the outside tissue, until then there's really not much inflammation that they stimulate. And characteristically they look a little bit like a blasto or crypto, but without the big capsule. And then usually you can see some sort of internal spherules, starch packages that are present to help in the diagnosis. Laryngeal lymphoid hyperplasia, youngsters, almost a no great shakes lesion associated with exposure to equine herpes virus can produce massive, mild to massive lymphoid hyperplasia in the pharynx, and sometimes respiratory disturbances associated with it. Atrophy unilateral of the muscles of the larynx, the characteristic disease, roar, laryngeal hemiplasia associated with laryngeal muscle atrophy, the long recurrent left laryngeal nerve that gets traumatized results in atrophy of the muscle such that it can't pull back the arytenoid fold. It stays in the lumen and produces the inspiratory stridor associated with roars. Laryngeal hemiplasia, roar, it's more of a clinical entity than it is from the necropsy standpoint, and is really pretty boring to work our way through. A little more interesting become masses that start to grow inside the sinus spaces. We've got polyps, cancer, and cryptococcus as consideration for nasal granulomas. Once they start to encroach upon a large area, it's one of two diseases. That's squamous cell carcinoma or cryptococcus. And I used to think that it was always going to be squamous cell carcinoma, but I hopefully brought it. Could show you the same photograph, very similar, and it's cryptococcus. So touch imprints over the surface or look for the lesion invading elsewhere. Lymph node, laryngeal tissue, necrosis, and then a desmoplastic sclerotic response characteristic of squamous cell, and you got it figured out. But that's what they make light microscopy for. Large squamous, lots of newts. Number one nucleated cell associated with squamous cell carcinomas are not the cancer cell, but the neutrophils, because they ulcerate through some surface that's exposed to the outside, and then a nice cluster of those cells there as well. Let's see, pathognomonic, aborted, newborn, foal, trachea, fibrino, necrotic, cast, or plug at the bifurcation. Essentially pathognomonic, so they say, for equine herpes virus. Equine rhinopneumonitis, microscopically, a bronchiolitis, lumen, inhaled squame in this location, necrosis, pycnosis, karyorhexis, maybe an inclusion, but that squame's even pointing right to a perfect inclusion located there for equine herpes virus. A couple more viruses or inclusion bodies over here, and then hints when you see this vesiculated chromatin pattern, but you search around enough and you can find those inclusions, viral culture as well. Neonates, stillborns, poor doing foals shortly after birth, consider equine herpes virus. Lesions in the liver, white foci, splenic necrosis to go with it. Pleuritis in the horse. Now there's edema. Massive amount of pleural fluid that's accumulated in this horse. Underlying the lesion very often is an abscess, pulmonary, something more than a primary pleuritis, but usually there's something in the parenchyma. However, you can get shipping fever type of pleurides, pneumonia, gangrenous almost, necrotic areas of pulmonary tissue. And if you look in many of those, you can find abscesses and you can squeeze purulent material outside of those surface. The stress, some other factor, is usually what precipitates the condition, and you can have material from there exude out into the pleural space and then produce massive fibrinous pleurities, pericarditis, and so forth. But you can have forms of shipping fever without the underlying lesions. Condyles, funny lesion, base of the skull, empyema. Guttural pouch, purulent material, Streptococcus equi, more common than mycotic. And I didn't know it, but once this stuff gets inspissated, then the term they'll use for that is a chondroid. So there's the chondroid of the inspissated material inside the guttural pouch. Unthrifty looking intermandibular space of a foal with expanded tissue due to big lymph nodes all through this area that when you cut them open exude out purulent material, bastard strangles, respiratory strangles, not dry land distemper associated with pectoral lesions in the horse in the west coast, but Streptococcus equi induced lymphadenitis. Cancer, mycotic. Cancer, mycotic. Granulomas and cancer really can look a lot alike, and you can get mycotic infections with these leeches of cores of dead necrotic material that you can pull out associated with phycomycosis and various mycotic organisms. Here's a neonatal foal stained with brown and bran. That's a great way to see these lesions of vernix caseosa, or the sloughed and then inhaled squames that are inside the respiratory tract. A little bit older foals will develop the adenoviral pneumonia associated with CID in foals, in which case there's proliferation, and there can even be type 2 hyperplasia of the lining cells. And of course, characteristically with this and with the inflammation, there'll be an interstitial pneumonia and then adenoviral inclusions. The adenoviral inclusions here are in a cytologic preparation and are easy to see, but are usually pretty easy to see in the histologic preps as well. And then they'll have pancreatic lesions associated with those also. And then if you see fuzzy-looking, nondescript material inside the lumens, get ready to diagnose pneumocystis carinii. And I just have a hard time visualizing these in H&E and even in the silver-stained sections. I don't think I brought an electron microscopic view, but you're always suspicious of it because it's an Arab foal, chronic immunodeficiency, secondary adenovirals, then they should pick up that unusual fungal agent. Abscesses scattered all through the surface, could be inhaled type of material or could be rhodococcus. Youngsters, 6 months of age, year of age, discrete granulomatous lesions with macrophages just packed with the organisms, constipated with them, and then these white chalky areas of necrosis and or purulent material. Heaves, if you ask me, is just like a roar. That's an ante-mortem type problem, and I just don't have much interest in it. From the necropsy standpoint, the heave line from the emphysematous lungs as they're trying to squeeze the air out. We used to talk about eosinophils and mast cells as part of the cytologic pattern characteristic of heaves, but with a variety of pulmonary diseases in the horse, there's no statistically significant difference in the population of mast cells and eosinophils that are present. And if it's a horse, you got to watch out for all sorts of contaminants that can come into cytologic and histologic preparations. In fact, if you take young foals and you culture tracheobronchial aspirates, you can pull out respiratory pathogens from as high as 30 to 50% of those foals. So it has to be correlated with other significant lesions. Gangrenous inhalation pneumonia, very often gas pockets or severe areas of necrosis if they live long enough inside the dead area, that's demarcated by this line. Plant material can be located inside of those, and they're not going to live long. Lungworms are not common in horses. You'll see it more commonly in donkeys and mules. And in this particular photograph, Dictyocaulus arnfeldi would be located all through here. Dictyocaulus viviparus, which are just packing the trachea and the bifurcation in this cow, a little bit different species, and are very common compared to the infrequency of Dictyocaulus arnfeldi. Big masses in the lungs, granulomas, mycotic, or cancer. Granular cell myoblastoma is one of the unusual tumors that forms in the lung, but of all the species, horses would be one you could see them in. Doesn't look right. Lung, heart, diaphragm, diaphragmatic hernia. Trauma, recent or a long time ago, and hernia and presence of GI tissue in the pleural cavity. Young horses have a funny arytenoid cartilage inside the nasal cavities and in other cartilage, in which you'll see this expansion and then these areas of hemorrhage and necrosis. Expansion of the cartilage, gray gelatinous material, and I don't know what the underlying cause is. Embolic shower makes these discrete gray areas all through the lungs. And then mycotic problems usually are associated with vasculitis, blood vessel, good wall, and then necrosis of the wall through this particular area, and then do the GMS stain or something to light up those mycotic organisms. We'll zip through a couple of these and then start on the reproductive system. Here's the placenta up close and personal in a horse, and that represents the cervical star. A couple no great shakes lesions that you should be familiar with. Cervical star, absence of placentation, epithelial covering for that part that goes into the cervix. Anytime it's shiny and reflects light, that's probably good. Anytime it's gray and crumbly, that's bad. Sharp lines of demarcation, bad. Color changes, bad. So here's placentitis in a horse. They can be hematogenous or ascending. They're almost always ascending. And then can be associated with windsuckers or poor rectal vaginal conformation that tip inward such that I can aspirate GI contents as well as air, hence the term windsuckers. And then they do the Kaslik surgeries to prevent it. The placentitis is characterized by necrosis, inflammation. Bacterial and or mycotic. The more pigmented organisms like this may well just be contaminants. Alternaria and various other ones, if the placenta sat on the ground for any length of time. There are some truly pigmented fungi, but they don't usually cause placentitis, skin lesions elsewhere. Sharp line of demarcation, big masses here, can be associated with hyperplasia of the allantois in the horse. The most common cause of the abortion in horses is twins. Small one, big one, double placentas. It's very rare that they get to go on to term, and then even rarer that both of those should live, although it does happen. Henceforth now, one of the reasons to do ultrasonography to diagnose pregnancy at around 17 days of gestation is to crush one of the embryos and let the other one go on to development. You need to do it earlier before there's implantation, when you can float the two embryos far enough apart so you can crush one. Here's hyperplasia of the allantois as a lesion described by Mike McEntee in horses. Here's mineralization that typically follows blood vessel patterns on the amnion of a horse, and this is always a no great shake sort of lesion, little beads. Here's a lesion that looks like it's real. We see it more frequently in ruminants as nice discrete plaques, but here's amniotic plaques that can form these circular pox-like lesions, and sometimes these can be yellow, gray, brown in color, and you think it's a significant lesion, and then squamous metaplasia all through this particular region. Little equine embryo, endometrial cups. Looks like sharp areas of demarcation, necrosis. Endometrial cups, no great shakes. Need to sort through those, the hypomanes, before you get on to the real lesions. Ovaries, distension, pyometria, or hydrometria, mucometria, something wrong with the cervix such that the fluid's not draining out. Pyometria, speculum, cervix, pus that's pooled on the floor of the vagina. Pass the stomach tube through the cervix, and you can fill a bucket with that pus in a really severe case of pyometria. In the horses, these guys will usually continue to cycle with their pyometria. In dogs and cows, it's associated with a persistent CL and high progesterone, such that cycling stops, and the high progesterone enhances the infectious nature. But in horses, they're a little bit different. They'll usually continue to cycle and have periods where they'll open and drain pus out of the uterus and into the vagina. Endometrial biopsy is used in the horse to help determine whether or not you can establish pregnancy in a horse in which they haven't been able to get pregnant and maintain their pregnancy. The abnormal side is on the left, the normal side for comparison, and then of course from the Kenny systems you go through different grades of 1, 2, and 3, and then subclassifications A, B if you want to. The key thing is that there's an absence of glands, there's inflammation that's present. Glands, no glands, inflammation that's usually mononuclear in nature by the time we see it. In fact, most of the pyometrias, if you look in the wall, it's still mononuclear over here, so don't ever expect to see much in the way of neutrophils. And then we'll get into an absence of glands and fibrosis in the deeper tissues when you progress into grade 3s, and then these would be the individuals that will be very hard to ever get pregnant. Preparturient edema, almost a no great shakes lesion in these maiden mares or first calf heifers as well, not associated with ruptured prepubic tendons. Paradoxical, secondary accessory sex organs in the horse, hind limbs, and then a clitoris that looks like a penis can be associated with hermaphrodites or pseudo-hermaphrodites, such that on this side we've got some ovarian tissue and mesothelial lining, invagination, and over here the attempts to start to form seminiferous tubules. When both gonads are located in the same animal, whether it's in the same side, same organ, doesn't matter, that's a true hermaphrodite, and that's really rare. Most commonly in veterinary medicine we see male pseudo-hermaphrodites that have ambiguity of the external genitalia, but we name them by the gonad. So as long as there's testicular tissue that's present, then it's a male pseudo-hermaphrodite, and then various degrees of female genitalia, clitorises, and so forth that form. And then, of course, we can produce hybrids, and the hybrids will be sterile and associated with hypoplasia of the reproductive organs. Cysts just don't occur in horse ovaries. When cysts are present, they're either part of a tumor, the granulosa cell tumor, or the sex cord stromal tumor, and in which case, if you go look, you'll eventually find some yellow tissue. And the reason I push for that is that the yellow tissue is what contains the interstitial cells, which is what are making the testosterone that produces the male-like behavior in either these nymphomaniac or mares that breed other mares. So it's not just the white stromal tissue, but go look for this yellow material, and then that's what contains the testosterone-producing cells. Other tumors besides sex cord stromal or the granulosa cell tumors are dysgerminomas. That's why they invented microscopes. You cut it open and you see what looks like a seminoma, blast cells with or without lymphocytic foci, dysgerminomas, and those are the ones that have been associated with hypertrophic osteopathy. Teratomas, hair formation, cartilage, GI tract formation can occur in the ovaries of any species, including the horse. Cystic ovaries don't occur in the horse. Parovarian cysts are a dime a dozen and are very common in the horse. In fact, most horses, if you look adjacent to the fimbria or in the oviduct, you can see some of these parovarian cysts. When you see a large cyst inside the ovary, it's probably a Graafian follicle that has ruptured, and they can be huge in cross-section, but cyst inside the ovary as compared to cows doesn't exist, or it's a granulosa cell tumor. Corpora hemorrhagicum can also be very large in the horse and can be even palpated per rectum, and you don't need to think of any other bizarre diagnoses. Paraphimosis, or inability to retract the penis, is oftentimes associated with a lesion, or chitis in this case, or has been associated chemically with the use of ace-promazine type of compounds. If the penis remains externalized for a prolonged period of time, it can become markedly edematous, and then you can have erosions and ulcers associated with it. This horse presents for colic, and the colic is testicular torsion, twist, not associated with the GI tract. This horse presents for colic, inguinal hernia, dead necrotic intestinal loops that have gone through the inguinal canal. Some of the vascular compromise. Now this is real common, and your differentials for these large masses are granuloma or neoplasia. Doesn't matter what system, we'll keep those two together. Ulcerated over the natural surfaces. And then here's one that forms masses. Habronomiasis, sarcoid, granulation tissue, squamous cell carcinoma. And then you look at those microscopically to sort your way through it, and there's a marked one. Don't want to hang on that photo too long, just too ugly to look at. But massive squamous cell carcinoma, you kind of wonder why they rushed the horse into the clinic. Touch imprint, just like some of the other slides we've looked at, numerous neutrophils, then large, well-differentiated squamous cells, and less well-differentiated that exfoliate with a squamous cell carcinoma, and then you see the same pattern histologically. Keratinization, intercellular bridges, versus if touch impression, neutrophils and numerous eosinophils, then we should start to think of habronomiasis, all the eosinophils that encase the granulomas, cut surfaces of the parasites, and marked eosinophilic granulomatous inflammation associated with it. Sarcoid, habronema, distal limbs, much more common than to think of squamous cells. So location helps you determine it. In any of those locations, once the proliferating connective tissue runs perpendicular to the blood vessels, then it's granulation tissues. In horses, distal limbs characteristically can make an excessive amount of granulation tissue. Vagina, vulva, lesions going around the external surface, squamous cell carcinoma, or coital exanthema. Equine herpes as another differential for those lesions. But that's a great location to also find squamous cell carcinoma. CNS will be the system that we conclude with: brain, pituitary, and we've gone through the pituitary adenomas that are so common in these old ponies. Curly hair coat here. We're going to ignore her curly hair coat and understand that most of those pituitary tumors are benign. Many of the old horses have cholesteatomas inside the ventricular space, cholesterol clefts, small granulomas. Only Dr. King would go through the effort of dissecting these out to demonstrate the granulomas that form and that are no great shakes. Hydrocephalus or various other skeletal anomalies can occur in the foal just like in any of the other species, and marked distension of the ventricular system. Arab foals, not ponies, have cerebellar abiatrophy, much like the Kerry Blue Terriers, in which case grossly the cerebellum may not look that abnormal, but on microscopic determination is when you can see the lesions in the basket cells and dropout of Purkinje cells in the cerebellum. And then an interesting lesion that can develop secondary to cerebellar abiatrophy is olivary nuclei and caudate nuclei necrosis. Vet pathology, let's see, Montgomery and Stortz have written this up, and these caudate nuclei are dependent upon intact neural tracts from the cerebellum to these nuclei, and it can result in necrosis. Cloudy material that fill the sulci, meninges, suppurative meningitis. Fibrinopurulent dorsal surface, and then particularly the ventral surface is a nice place to look for those areas of meningitis, and then sometimes microscopically it's just a piece of cake to diagnose because there's thick meninges and filled in with the neutrophils. Gram-negative E. coli, this guy could well be associated with synoviitis, osteomyelitis, or ophthalmitis, as this septicemia disseminates all through the animal's body. When they turn into abscesses, are characteristically located at the junction of white and gray matter and make those discrete abscesses, right at that junction. Neoplasia, the CNS, is incredibly rare in the horse, but abscesses that are small or then expand to this tissue are characteristic, especially at the white and gray. This horse with inability to walk, swallow food, is a great one to consider hemorrhage inside the spinal cord, which is associated with equine herpes virus, or when really severe, protozoal myelitis. That's a great place to stop the talk, since these protozoal organisms are really common in multifocal areas of severe hemorrhage and necrosis. Sometimes they're hard to see, sometimes they're easy to see. Sarcocystis neurona. That's the prettiest photo you're ever going to see of it. It's a great place to stop this discussion of horse pathology, and hopefully we can continue with some of the other